Good morning. This is a regularly scheduled meeting of Panel A. My name is Janie Wright. I'm the chair. Can staff please come forward and take roll?
Dr. Bishop?
Here.
Dr. Hawkins?
Here.
Dr. Lewis?
Present.
Mr. Serrano Sewell?
Present.
Ms. Yaroslavsky?
Present.
Dr. Yip?
Present.
Ms. Wright?
Present.
We have a quorum.
Thank you. I'd like to thank Judge Cohen for being present with us. He will be helping us with the evidentiary matters as well as keeping track of time. So our first item is an oral argument on petition for reconsideration. And council are ready council is ready to proceed?
Yes.
Okay.
Yes, we are.
Okay.
All right, I will now open the record for oral argument on respondent's petition for reconsideration of the decision issued in the matter of the accusation against Lois Ann Freisleben Cook, MD, a physician and surgeon, certificate number G45968, case number 16-2013-234512, OAH number 2014-03-0614. Today is May 7, 2015. It's 10 a.m. We are at the Los Angeles Airport Marriott Hotel. My name is Howard Cohen. I'm an administrative law judge with the Office of Administrative Hearings. I've been assigned to sit with the medical board, which is convened here today to hear oral argument on the petition for reconsideration. Court reporter is making a transcript of this proceeding. Could I please have the parties state their appearances?
Yes, my name is Amelia Burrows. I'm the attorney for respondent Lois Freisleben Cook, who is also present this morning.
Good morning.
Good morning.
I'm Lois Freisleben Cook.
Good morning.
Good morning, Your Honor. Good morning, panel members. My name is Josh Tompley. I'm a Deputy Attorney General representing the complainant today.
Good morning. All right. The respondent licensees council will have 15 minutes for opening argument. The Deputy Attorney General will have 15 minutes for responsive argument. Then each side will have 5 minutes for closing. If respondent wishes to address the panel personally, she may do so, and I will swear her in. All argument must be based on evidence in the existing record. No new evidence will be heard, even if offered in response to a question from a member of the panel. I have reviewed the decision, but I have not reviewed the transcript or the exhibits. Therefore, it's up to counsel to object if he or she believes that the other party is citing new evidence, in which case I'll ask the other party's counsel to please cite to that evidence in the record. All right, thank you. You may proceed.
Thank you. And do you mind if I stand?
Not at all.
All right, thank you. As I said, my name is Amelia Burrows. I'm the counsel for Dr. Cook, who is present this morning and will be addressing the panel. By way of introduction, Dr. Cook has a medical degree from UCLA School of Medicine. She went on to complete her residency at Cedars-Sinai.
I'm sorry to interrupt, but we need the mic. Thank you.
Okay. I will sit. She went on to complete her residency at Cedars-Sinai and followed with fellowships at UCLA in developmental disabilities, pediatric genetics, and mental retardation. She then served at the Centers for Disease Control, working in the epidemiology of birth defects and developmental disabilities. She has also worked at the Department of Defense as a pediatric consultant for more than a decade. Her ability to complete a rigorous education and training, as well as her long history of work at these organizations, are indicative of her ability to identify the profession's best practices and incorporate those into her work. While in Germany, Dr. Cook met and married her husband, and together they returned to his home state of North Dakota, where Dr. Cook opened a pediatric clinic. The clinic had a patient population from North Dakota as well as Montana. And Dr. Cook primarily saw children who had special needs. It is the events and circumstances from North Dakota that bring Dr. Cook before the board today. The state of California has taken action against Dr. Cook's license. The first reason is for an admitted failure on Dr. Cook's part to timely complete electronic medical records. And the second was for establishing and maintaining appropriate borrow and return policies and practices at her clinic for federally funded for federally funded vaccines. With respect to the medical records, Dr. Cook readily admits that she did not complete those records in a timely manner. By way of background, Dr. Cook's EMR at the clinic in North Dakota required that before patient records are signed and finalized, that they be coded for insurance purposes. Dr. Cook's experience was that it took approximately 10 to 15 minutes per record to code. So those records remained in a suspended status until such time as Dr. Cook could code them and sign them. Dr. Cook did, however, memorialize her encounters with patients, her impressions of the patients, as well as her plans for treatment. The record was also available to other providers in the clinic before it was signed, coded and signed, so that they could provide patient care. And it was available to staff at the clinic if they needed access to the record in order to make referrals or request documents. Recognizing her own deficiencies at the clinic's EMR, Dr. Cook requested and received additional training from her EMR vendor. And to date, Dr. Cook completes all of her medical records in a timely fashion at both clinic and hospital. As you are aware, Dr. Cook has a prior disciplinary matter concerning a failure to document in 2 patient records, as well as prescribing to her adult daughter on a single occasion. As a result of that discipline, Dr. Cook was required to take a PACE course in medical record keeping, which she completed in 2008. That course largely focused on the appropriate content of medical records, not necessarily the best practices for EMR. Dr. Cook found the course to be useful, and she's applied it to her own practice. With respect to the issue of vaccines for children, Dr. Cook's philosophy forgive me. As you know, Dr. Cook had a subsequent disciplinary action in the state of North Dakota in 2012. She was again required to take a record-keeping course, complete it with PACE, which she did. That particular course focused on the administration and completion best practices with respect to electronic medical records. And Dr. Cook also found that course to be extremely helpful and has incorporated it into her practice. With respect to the issue of vaccines for children, Dr. Cook's philosophy and practice in North Dakota was to use every patient encounter as an opportunity to update the child's vaccine record. Essentially, this was Dr. Cook's effort to increase the vaccination rates in her community. At the clinic, they administered a federally funded vaccine through North Dakota's Vaccines for Children, as well as vaccine stores for private pay patients. In 2010, Dr. Cook's clinic had a borrow-return practice, meaning that if, on occasion, one vaccine inventory was not available for a child currently at the clinic, inventory was borrowed from the other, so that at the end of the day, the child present in the clinic received vaccination. At that time, Dr. Cook understood that there was no formal process with the state to document VFC borrow and return of inventory at the clinic. The method for keeping track at her clinic of inventory borrow and return was simply a whiteboard, and 3 nurses in charge of vaccinating children at the clinic would keep track of inventory by marking on the whiteboard. Due to a weather event beyond Dr. Cook's control, her clinic lost its vaccine inventory. Dr. Cook appropriately contacted the VFC program in North Dakota and very candidly, when asked, said yes, that it provided VFC vaccines to private pay patients. As a result, the clinic's VFC status was terminated, and eventually Dr. Cook and the state of North Dakota arrived at a stipulated agreement. That agreement was admitted at hearing, and it's in the record as Exhibit A. There was no admission of liability by Dr. Cook or factual merit, only that VFC eligibility records were not consistently entered at her clinic. And I refer the panel to paragraph C1 of Exhibit A. Dr. Cook's understanding is that she today remains VFC eligible, and her licenses in North Dakota and Montana are unrestricted. And because the record reflects descriptions of Dr. Cook's credibility at hearing, Dr. Cook is prepared to speak this morning. And you will have an opportunity to see that Dr. Cook, like all of us, has certain idiosyncrasies and mannerisms in public speaking that perhaps were underappreciated or not appreciated by the administrative law judge at hearing and by the state. And I thank you for your time today and turn it over to Dr. Cook.
Dr. Cook, please raise your right hand. Do you swear or affirm that your testimony in this proceeding today will be the truth, the whole truth, and nothing but the truth?
Yes.
Thank you. And I caution you, please testify only to matters that are already in the record before the panel. Thank you.
I really just want to say that I do understand why I'm here today. I understand the concerns of the board. I have a healthy respect for your concern and for your need to keep the patient and public safe. I really do. I also understand that I didn't do things as well as I could have. I was very busy. I didn't code and close records fast enough. And our policy of keeping track of Montana patients getting vaccines, VFC versus private borrower return, was one that I turned over to others and didn't provide sufficient oversight for. I know that I could have and should have done things differently, and I've learned that not having done so obviously has consequences, okay? I feel that now I am able, based on what I learned at the last PACE course, to get the electronic medical records done, and done very timely. I've been providing care at the Oroville Hospital. I'm currently providing care at a federally qualified health clinic in Santa Barbara, and I get my records done within 24 to 48 hours, which is the guideline that they have. And I'm able to, even with 3 different EMRs now, with big learning curves, able to plow through and get those done because I don't try to wait until I have everything in. I don't try to wait for outside records. I don't do all of the stupid things I did before. Okay, so I think I'm doing a better job of this. I'm not any longer responsible for a VFC program, but I do want to mention that there was never at any point at any time with the VFC program any intention on my part to take advantage of the VFC program or to profit from it. In fact, the entire time I was in North Dakota and had my clinic, I didn't take any pay from the clinic. We donated that clinic to that community as a gift, as a way to give back, because that community had been very needy. So there was no ill intent on my part, but there was poor oversight of the process. So I guess what I want to say at this point is I understand that I made mistakes. I understand why they were serious enough to lead me to this point in time today. And I would just like to ask that you consider letting me continue to practice medicine, given that I am doing my absolute best to do everything the way I should now. And that's all I have to say.
Thank you.
Anything further?
No, thank you.
All right, thank you. Mr. Template, you have 15 minutes.
Thank you, Your Honor. The licensee requested to have oral argument today, and I'm just going to add just a little bit to the written argument that I've submitted. I'll be very brief, but I just want to highlight a few points. In short, this is a case about real errors and real misconduct that was compounded by, as the ALJ found in the decision, a lack of candor on the part of the licensee in her testimony under oath at the hearing. And unfortunately, the board will not have the opportunity to witness firsthand some of the evasiveness and the lack of forthrightness that the licensee demonstrated at hearing. And all I can do is point you to the written argument where I've highlighted a few points in the transcript where this licensee was plainly evasive. And I think then the penalty here reflects that. It's more than just the errors and the misconduct. It was compounded by multiple findings by the ALJ of evasiveness. So just briefly then, on the two different types of misconduct at issue, the first is the record keeping. The details of the record keeping are in my argument. I think I'd just like to point out a few highlights. One is the licensee's attitude toward this record-keeping error. At the hearing, she was asked by her attorney to explain the basis for the North Dakota discipline regarding her record-keeping. And Dr. Cook said, quote, "The complaint was that in my electronic medical record system, I wouldn't finalize my records until after I had coded them, and so they would stay in my inbox unsigned and waiting to be coded for longer periods of time than the North Dakota board would like." To me, that choice of language suggests disagreement with the North Dakota board's finding that medical records should be timely submitted. I want to share one other quote, and this is in the more recent written argument submitted to the board today. The licensee's brief says, quote, referring to unsigned and incomplete patient records, quote, "Having records remain in Dr. Frieselman Cook's electronic inbox did not prevent or hinder appropriate patient care should the child be seen in the interim." I think that fundamentally misstates the basics of medical record keeping. The licensee has had 2 required medical record keeping courses, and yet this phrase appears in today's brief. Isn't the point of medical record keeping to ensure timely documentation of a patient's medical record, contemporaneous and accurate reference for future patient visits? Isn't it plainly compromised when records remain suspended, incomplete, unsigned? And last, I just want to highlight a few of the issues with the vaccination program. This is the second leg of misconduct. There's no dispute that Dr. Cook's clinic was terminated from the North Dakota federally funded vaccination program for children for violating its rules and for mismanaging its vaccines. Further, the licensee never produced any proof, apart from evasive testimony, showing that her clinic was ever reinstated to that program. To this day, she is not allowed to dispense vaccines in North Dakota. She has since moved to California. So last, I want to address the point that the board has, I think, asked us to focus on: penalty. The licensee rejects any probationary form of discipline. The 5 years recommended by the ALJ who heard this matter, the 3 years initially imposed by the board, and apparently even 1 year of probation is too much. It is her view that she should receive only a letter of reprimand. That would be her second letter of reprimand by this board. A letter of reprimand can hardly be appropriate for a repeat offender, particularly one who has been found to lack candor and to be less than forthcoming while testifying under oath before an officer of the board. The ALJ, who heard this case and recommended 5 years of probation, based his decision on the same evidence now available to the board. And as I said, he also had the benefit of observing firsthand the licensee's testimony and evasiveness to relatively simple questions. Let me just direct the board to one example of the licensee's testimony in the transcript that you have at page 39, line 6. For 8 pages, there is evasive testimony. Page 39, line 6 through page 47, line 12. I and both the court asked a simple question to the licensee, and she dodged the answer. The licensee argues in her written argument that she was honest and forthcoming at hearing. That was not the case. And looking through the decision, you'll find at least a half dozen examples by the ALJ that said that she was not being forthright. She was not expressing candor. She was not answering the basic questions that I had on behalf of complainant and that the court had on behalf of the board. For these reasons, I urge the board to impose the penalty of 5 years of probation. Thank you.
Ms. Burrows, 5 minutes.
Can I use one? Sure. Is it all right if I respond to that?
You may.
I did read Mr. Template's complaint about lack of candor, and I have to say, during the times where he thought I was being evasive, I was actually not understanding precisely what it was he was asking. I was trying to answer his questions, but I didn't quite know what he was trying to get at, and he was asking things that I tried to answer to the best of my ability, but I obviously didn't understand the question well enough. The issue of having records, in a state of suspense, I agree now that this is not something that's acceptable, but I do know that I, for example, if I send for records from Mayo Clinic or from places like that, I'll often get records that say this is unsigned and maybe different in its final form. My records were equally available to go out to people even before they were signed, and it would say they're unsigned because they're not coded. So, even though now I don't do that anymore, I didn't realize that it was taken that way by Mr. Template and by the administrative law judge. And I didn't at any point try to mislead him or to not answer his questions honestly. I just didn't understand what he was asking, and I have a tendency sometimes to talk too much. And my attorney had said, just be brief in your answers, just answer your questions. And so I was trying not to talk too much, and I think I wasn't coming across right. And I understand that, but I wasn't in any way trying to be evasive of Mr. Template at all. And I'll be happy to answer any of his questions right now.
Anything else? Ms. Burrows?
Yes, thank you. I would just direct, with the issue of Dr. Cook's candor, there is a very clear question and answer on the transcript, beginning at page 23, line 18, through 24, line 2. And that is the question and answer where Dr. Cook addresses the question about whether or not she is VFC eligible and whether or not she gave VFC vaccines subsequent to the state's action with respect to the borrow return policy. So I would commend to the panel that portion of the transcript. And in conclusion, Dr. Cook suffered a period, admittedly, where her record keeping did not meet the best practices today. She has recognized that failing. She is incorporating into her practice best practices. She works every day to prevent any further additional concerns. The state has not identified any practice or implicated Dr. Cook's ability to provide timely and appropriate care for children. And that would be more deserving of such a penalty. And we thank you for the time today.
May I make one statement? May I say one thing? I don't feel that I'm not arguing against probation. What I'm asking is that if I am on probationary status, then I will lose my board certification, which will make me ineligible to work in a lot of the places that I am working now. I do focus on underserved areas, federally qualified health clinics, and if I'm not board certified, I won't be eligible to do that anymore. But I would be happy to agree with any kind of oversight that keeps me from having a compromised license so that I don't have to lose my board certification. That's the only reason I was objecting to probation. I don't mind reporting to somebody, having somebody review my records. I don't mind any oversight at all. It's just that if my license is on a probationary status, the Board of Pediatrics will revoke my certification. So, anything else? That's it.
Is that it? Mm-hmm. Thank you very much. Mr. Template, 5 minutes.
Thank you. the licensee says she has no objection to probation, but she leaves the board with no means to address the discipline that the misconduct that she's committed apart from discipline, apart from probation. Probation, as the board knows, is the only way to allow the board to have oversight over a licensee. There's simply no other way to make sure that her record keeping is proper and timely, to ensure that all the conditions that I've recommended in the written argument, none of those can be imposed or provided oversight without probation. So there must be probation. It is inconvenient for the licensee, but there's no such thing as voluntary compliance for 5 years, or do your best for 3 years, or promise for 1 year. There must be probation. She's left the board with no other choice. Thank you.
Thank you. I'm going to ask the panel members if they have any questions, and please keep in mind that in answering, you are only to refer to evidence that is already in the record. Thank you. Do any of the panel members have questions? Go ahead.
If this is not in the, excuse me, if this is not in the record, then you can strike it. But I have a question about the frequency of the VFC audits. I thought I saw something in here about...
We can't hear you. Can you move the microphone?
You probably can't hear me with my voice either, but...
That's better, thanks.
Better. Sorry about that. The frequency of the VFC audits, I thought I saw somewhere in the record, and if I didn't, then, we can't present it. The frequency of their audits to recognize issues up front. I don't understand how frequent they stop by and...
There was only one
Your
audit
records.
that I requested, and that audit found that there was about $5,000 worth of VFC vaccine that was given to private patients and billed to private insurance. The rest of, the other figures that came out of that whole action were based on extrapolation from the database, but the database I hadn't properly entered. For example, I hadn't given, if I gave a patient from Montana VFC vaccine because they were VFC eligible, we put that into the Montana database, not the North Dakota database. If we gave somebody who was a private patient private vaccine and later found out that they were not eligible, then we replace that with VFC vaccine and then use that on a private patient. And those are the things that led to the database having a big discrepancy. But the audit, when the audit was actually done, it found a $5,000 discrepancy in VFC vaccine given to private patients and billed to private insurance.
So are you saying that they don't audit these databases frequently, the VFC program? I
don't know how they audit it. They would come and do the routine visits to our clinic, but they didn't come very often because we were pretty far from Bismarck. And they would come and do the training that was necessary. But they hadn't done any prior audits, not until we called and made a large order because we'd had a storm. And we had a storm. The vaccine that I took to the hospital ended up being ineligible because even their backup power went out. And so we had to request new vaccine.
And your EUHR system allows you to put patients, does it allow you to put patients on sort of hold until the record is completed?
Now I don't put anything on hold. Now I finish the record with what I have at that moment. I used to wait until I got outside records in because I would be doing kind of complicated consults. So I'd wait till I got the outside records in to do a final, really comprehensive report. I don't do that anymore now. Now when I see the patient, I document what I know at that time, and then when I get extra material in, I write another note.
Okay.
So that everything's signed off on now.
Okay, thank you.
Any further questions? Yes.
So your license in Montana and North Dakota is restricted or unrestricted?
No, unrestricted.
Unrestricted. Okay, thank you.
Any further questions? All right, that being the case, the matter is submitted, the record is closed, and we will go off the record. Thank you very much.
Thank you.
We will now go into closed session, so we'd ask that everyone that is not supposed to be here, please leave and come back in an open session. Thank you.
Okay.
Good afternoon, everyone. Welcome to a meeting of the Medical Board. We'll now begin. I want to ask all of us to please turn our cell phones to silent and make sure they are off the table so we can avoid unnecessary feedback. You may notice board members accessing their laptops during the meeting. They are using their laptops to solely access board materials and that are on an electronic format. This is an official meeting of the Medical Board of California. As such, disruptions of the board's business will not be tolerated. We have designated time on each of the agenda for public comment and ask for public comment on each agenda item. I ask that you be respectful of the need to conduct the board's business. Should anyone disrupt the meeting, I will ask the person to conduct himself or herself in such a manner that permits the board to transact its business. The meeting will be available via teleconference. Individuals listening to the meeting will have an opportunity to provide public comment and will be assisted by a moderator who will be facilitating the teleconferencing process. For those members of the public participating via teleconference, please wait until the monitor has introduced you before you make your comments. To request to make a comment during the public comment period, press star 1. You will hear a tone indicating that you are in the queue for comment. If you change your mind and do not want to make a comment, press the pound sign. Assistance is available throughout the teleconference meeting. To request a specialist, press star 0. Each person will be limited to 3 minutes per agenda item. However, during agenda item 2, public comments on items not on the agenda, the board has limited public comment period for individuals on the teleconference to 20 minutes. In addition, public comment from individuals here at the meeting will be also limited to 20 minutes. Therefore, after 20 minutes, no further comments will be accepted. During public comment on any other agenda item, 10 minutes will be allowed for comments from individuals on the teleconference line and from those in the audience. After 10 minutes, no further comments will be accepted. Business services staff will be assisting me with receiving the public comments via teleconference during the meeting. The board welcomes public comment on any item on the agenda, and it is the board's intent to ask for public comment prior to the board taking action on any agenda item. If for some reason I forget to ask for public comment on an agenda item and you wish to speak on that item, please raise your hand and you will be recognized. I would like to remind all speakers to complete a presenter's slip. Here's an example of one. So I can call on you by name at the appropriate time and that the record of this meeting can be full and complete. The speaker slips will go to Liz in the back. If you could raise your hand. Thank you. I will do my best to call upon everyone who has supplied a slip for the agenda item and recognize those who wish to make any last-minute comments. But we ask you to fill out a speaker slip for your comments so we have it for the record. We plan to end today at 5 p.m. I will be taking some items out of order to accommodate this afternoon's schedule. Before we begin to the official business, I want to take an opportunity to welcome 2 of our newest members of the board and continue a great tradition of the board, and that is to have a ceremonial administering of the oath of office. We do this to welcome you to the board and to the public and for our newsletter. And it's such a great honor. I will start with Dr. Bolot. She is a professor and executive vice chair of the Department of Family Medicine at the David Geffen School of Medicine at UCLA. In 2004, she was elected to the board of California Beach Cities Health District, serving the communities of Manhattan Beach, Hermosa Beach, and Redondo Beach. She was appointed by Supervisor Don Knabe to the Los Angeles County Public Health, and she serves as a commissioner on that important board. Throughout her career, the doctor has worked to improve access and quality of care for all patients, including the vulnerable and underserved. She co-founded the UCLA International Medical Graduate Program a nationally recognized effort to increase the number of bilingual family medicine physicians serving the medically underserved rural and inner city communities. Dr. Bolat is a former leadership fellow of the National Hispanic Medical Association and has received the Los Angeles County Department of Health Services Recognition of Service Award for her leadership and dedication. It is an honor to have you join our board, and if you would please step up, I will administer the oath. Thank you. On behalf of my colleagues. Sure. That's probably a good idea. As a lawyer, I didn't want to do what Justice Roberts did and sort of botch it, as he did to the president, so I had it printed out in large font and provided you a copy of it as well, and we'll just do it line by line, if that's all right. Certainly. Okay. I please state your name.
Michelle Bolton.
Foreign and domestic.
That I will bear true faith and allegiance.
That I will bear true faith and allegiance.
To the Constitution of the United States.
To the Constitution of the United States.
And the Constitution of the State of California.
And the Constitution of the State of California.
That I take this obligation freely.
That I take this obligation freely.
Without any mental reservation or purpose of evasion.
Without any mental reservation or purpose of evasion.
And that I will well and faithfully.
And that I will well and faithfully.
Discharge the duties upon which I am about to enter.
Discharge the duties upon which I am about to enter.
Welcome.
Thank you.
Welcome. And if you would please share a few comments, if you wish.
Yes,
Commissioner?
I want to say to my fellow board members, the medical board, the Department of Consumer Affairs, and certainly our governor for appointing me to this, what I consider to be a very critical commission that is put together here. And I want to thank the people that are out there in the audience and those patients that are all patients at some time. So I feel very strongly about the role of the Medical Board of California and its mission, and I'm so pleased to be here to serve.
Thank you. Thank you, Doctor. Next, Dr. Hawkins has been in private practice since 1985. His medical practice, excuse me, is composed of primary care, pulmonary and critical care medicine, and hospice care. He is board certified in internal medicine and pulmonary and critical care medicine. He is a clinical assistant professor of medicine at the Charles Drew University of Medicine and Science. Dr. Hawkins is the president of the Charles R. Drew Medical Society of Los Angeles and is a member of the Golden State Medical Association of Thoracic California and the National Medical Association of the American Thoracic Society, as well as that society for the state of California. He is also a member in good standing with the Trudeau Society of Los Angeles. We are honored and pleased to have you join us, Dr. Hawkins, and the Governor made a great appointment. That's your copy. Thank you. I, please state your name.
I, Randy Hawkins,
do solemnly swear
that
I will support and defend
the
Constitution of the United States
and the Constitution of the State of California
against all enemies, foreign and domestic, that I will bear true faith and allegiance
to the Constitution of the United States
to the Constitution of the United States
and the Constitution of the State of California,
and the Constitution of the State of California,
that I take this obligation freely
that I take this obligation freely
without any mental reservation or purpose of evasion,
without any mental reservation or purpose of evasion,
and that I will well and faithfully discharge the duties upon which I am about to enter.
Discharge the duties upon which I am about to enter.
Thank you, Doctor.
Thank you, Gary.
It's two incredible additions to the board. Dr. Hawkins, would you care to make?
Just that I'm extremely pleased to be given the opportunity to serve and to help execute the mission of the medical board. Thank you very much.
Thank you, Doctor, and welcome. I would like to call this meeting to order and ask that Ms. Toof please call the roll.
Dr. Bolot?
Present.
Dr. Bishop?
Here.
Dr. Gonadev?
Here.
Dr. Hawkins?
Here.
Dr. Kraus?
Present.
Dr. Levine?
Here.
Dr. Lewis?
Present.
Dr. Yip?
Present.
Mr. Louie? Ms. Pines?
Here.
Ms. Shipsky?
Here.
Ms. Wright?
Here.
Ms. Yaroslavsky?
Present.
And Mr. Serrano-Sewell?
Present.
Thank you.
We have a quorum. Moving on to agenda item 2, public comments on items not on the agenda. Do I have any speaker slips? I have one speaker slip. Lisa McGeffert. Hello.
Good afternoon. I'm Lisa McGiffert. I'm the director of the Consumers Union Safe Patient Project. And I'm here today to ask the board to put something on the agenda for the July 2015 meeting. We're asking you to put on the agenda to discuss changing guidelines so that all physician probation orders include a requirement to notify their patients. Back in 2012, the staff proposed this as a recommendation during the sunset process, and that recommendation was rejected by the board. But as it stands now, physicians are required to provide a copy of their disciplinary decisions and accusations to every hospital where they have privileges or membership, and any facility where they engage in the practice of medicine, as well as to all of their malpractice insurance carriers. All of these entities are entitled to know of the disciplinary action. Only the physician's patients are left in the dark. It is unreasonable, we think, to expect all patients to consult the profile that's available on the website, which we totally support, especially patients who have an ongoing relationship with a doctor who might have been disciplined while they were still seeing that doctor. And it's a very, a lot of people don't even know the medical board exists, and we are doing what we can to try to help raise that awareness, and I know you would like to do that too, but it's not reasonable to expect people to know that that's where they can go to get information. So we're recommending that the board amend its guidelines to make it as a standard condition of probation that physicians who continue to see patients while on probation advise their patients of their status. And we are asking you to put this on the July 2015 agenda. Thank you.
Thank you. I have no additional speaker slips. Are there any speakers on the telephone on agenda item 2?
On the line.
Hello? Do we have any public comment?
Not at this time.
Okay, thank you.
Thank you. We'll now move on to the next agenda item. Agenda item 3, approval of the minutes from the January 20th through, is that the right date?
January 20th.
Yeah, January 23rd, 2015 board meeting.
I move to.
Just one second.
At each of your tables, there was a comment that was received after the packet had gone out, some changes that needed to be made, and so we've provided those to you. They're also on the back table for those in the audience, and they were also posted on our website, and so it's the page 25, some amendments to the bottom of that page and the top of the next page in some statements that Ms. Felmuth had made. So staff has incorporated those, and if the motion would be to accept them as amended.
Okay, I'll move to accept the minutes and the amendment.
There's been a motion and a second to approve the minutes as amended. Are there any comments from the public? Seeing none, are there any public comments from the telephone?
Hello, do I have any public comments on the line?
Not at this time, but again, that is star one.
That's star one, correct? Yes.
Correct. There's none.
Thank you.
I don't think we have any comments. Thank you. All right, appreciate that. Thank you. The motion's been made and seconded. Ms. Toof, would you please call the roll?
Absolutely. Dr. Bolat?
Abstain?
Dr. Bishop?
Aye.
Dr. Gonadev?
Aye.
Dr. Hawkins?
Abstain.
Dr. Kraus?
Aye.
Dr. Levine?
Aye.
Dr. Lewis?
Aye.
Dr. Yip?
Aye.
Mr. Louie? Ms. Pines?
Aye.
Ms. Shipsky?
Abstain?
Ms. Wright?
Aye.
Ms. Yaroslavsky?
Aye.
Mr. Serrano Sewell?
Aye.
Thank you.
The motion carries. Thank you. I'll now take agenda item 5 and defer 4 until a later part of the agenda. And that's agenda item 5 is the President's report. Dr. Gnanadev and I continue to meet with the board's executive staff to discuss projects at the board and to ensure everything is moving forward as needed for the board meetings. I want to thank our executive director and her staff for participating in those calls and assisting the both of us in developing the agenda. I also wanted to share with the board members a very successful first, what will be an annual legislative day that was held on February 26, 2015. I, along with a couple of my colleagues, and I would ask for their input as well, and staff, convened in Sacramento. We had scheduled a meeting with legislators, chairs of committees, in which we spoke to them, told them about our mission and the work that we're doing. Our meetings were appreciated, welcomed, and there was a real dialogue between the members, the legislators, staff, and members of this board. They also provided us what I thought sort of keen insight on their views of us, which is always interesting. And I'm happy to report they think we're doing well and staying true to our mission, which we are. There were some themes that I thought came out of it, one of which, when we get to it on the agenda, that's the ISOs. The legislators asked questions about the ISOs, and with that, I consulted with our executive director, and we put together the agenda item that you see in your packet. But it was a very successful day, and I welcome other members who participated, Barbara or Ron, to comment if you wish. You don't have to.
No, I agree, and the only comment I'd like to make is that some of the members really weren't as familiar as you would think about the mission of the medical board, so it gave us an opportunity to really help define who we are and what our mission statement is, and for that, I think it was a very worthwhile event, and I think it we will, according to our president, will be doing this in the future, and we will welcome it.
I would like to echo those remarks. I found the legislators and their staff that we met with to be totally engaged and queried us about different issues, and we were able to participate and inform them, and also to look to further collaborations with the opportunity of possibly using newsletters that they run with issues that we have, and to share ideas and share information. And I want to thank the chair and the staff extremely for putting this together. It's not an easy task, and getting those appointments is a challenge. Legislators are very busy, but they all represent consumers, and that's why it was so important that we're there. And I want to thank again our chair for making this happen.
Thank you. So thank you to members Pines, Yaroslawski, and Lewis, and staff for participating in that day. That concludes my report. I would like to draw the members' attention to BRD 5A-1 and 5A-2. This is a current version of the board's committee roster. With the addition of our 2 new colleagues, I wanted to put the roster in the board packet in case any members wanted to consider changes to their committee assignments. If you are interested in being on a committee or changing your committee assignment, please let me and Ms. Kirkmeyer know. For my report, I'd welcome any public comment from those in the audience. There's no action item, but if there are any comments from the public on my report. Okay, seeing none. Are there any comments from the phone?
Do we have any comments on the line? Thank you.
Thank you. Moving on to agenda item 6, discussion and possible action on legislation regulations. Okay. Thank you.
Hello.
Good afternoon.
Good afternoon.
Does everybody have their packet?
There's a big ledge packet this time around. And you should have a little package of updates because some bills got amended since that was actually sent out. So you should all have the updates, and there's also updates on the back table. I'd like to report that I've contacted all legislative district offices in the Los Angeles area, and we actually do have at least one staff from one of those offices here today. Also, we had to notice legislation on our agenda a bit differently this time. So previously, we didn't have to list all the bills we were going to discuss until the ledge packets went out. Now we have to list each bill on the agenda that goes out in the first mailing, and if the bill is not on that list, then we cannot discuss it at our meeting. And so it's a little bit different from what was before. And so basically what I did is listed all the bills that we could possibly have to talk about, but we won't be going over all those bills. So if you notice a difference between the two, that's the reason why. So as I said, there's an updated packet. On the tracker list, if you refer to the tracker list, the bills in blue are 2-year bills, or we've already taken positions on, so we won't be discussing those at this time. The bills in pink are the board sponsor bills, and the bills in green will require discussion and a position. I believe that we might be taking this a little bit out of order.
In deference to one of the authors, staffers being present at today's meeting, if it's okay with the board, I'll take SB 482 first. Seeing no objection. So if you can turn to SB 482. Ms. Simoes?
Okay, great. If you go to the SB 482 tab, this is the bill that would require a prescriber to access and consult the Cures database for the electronic history of controlled substances to a patient under his or her care before prescribing a Schedule 2 or 3 controlled substance for the first time to that patient, and at least annually when that prescribed controlled substance remains part of his or her treatment. If the patient has an existing prescription for a Schedule 2 or 3 controlled substance, the prescriber shall not prescribe an additional controlled substance until the prescriber determines that there is a legitimate need for that controlled substance. This bill would specify that failure by a prescriber to consult Cures as required would be cause for disciplinary action. The licensing boards of all prescribers authorized to write prescriptions for controlled substances would be required to notify licensees of this new requirement. And the bill would specify that a prescriber is not in violation during any period of time in which a Cures database is suspended or not accessible. This bill would further specify that the requirements in this bill are not operative until DOJ certifies that the Cures database is ready for statewide use. And the board believes Cures is a very important enforcement tool and an effective aid for physicians to use to prevent doctor shopping. Requiring all prescribers to consult the Cures system will allow prescribers to make informed decisions about their patients' care And the bill would also require the cures to have capacity to handle this workload before the bill becomes operative. This bill would further the board's goal of consumer protection and take steps forward in addressing the issue of doctor shopping and opioid abuse. For these reasons, board staff is suggesting the board support this bill. And as the president mentioned, we do have a member from the Senator Lara's office here to provide some testimony. Ms. Sorrow.
Ms. Sorrow, welcome.
Hi, my name is Sulie Sorrow. I'm here on behalf of State Senator Ricardo Lara, the author of Senate Bill 482. Senate Bill 482 will simply require prescribers issuing Schedule II and III drugs to consult California's Controlled Substance Utilization Review and Evaluation System cures before prescribing. Prescription drug overdoses claim tens of thousands of lives every year. According to the Centers for Disease Control and Prevention, drug overdoses are the top cause of accidental death in the United States. States like New York, Florida, and Tennessee have required prescribers to check their respective state drug monitoring systems and seen dramatic decreases in drug overdoses and deaths. We know that mandatory checks work and save lives. However, in California, checking the cure system remains voluntary. We have the system in place. It's time to implement a policy that has proven successful across the country and requires providers to consult the cure system before prescribing. Thank you, and I respectfully request your support of this measure. Do I go back?
Thank you very much, and please send our regards to the senator.
I will. Thank you.
Before we take a motion, do the members want to have a discussion and questions about this bill that pleases the board? And I'll look to my right. Dr. Hawkins?
Yes. As a physician in private practice, I find the cure system to be very easy to use and very, very helpful.
Thank you, sir. Dr. Kraus?
We have great faith that the Cures database will be instantly available in our offices, but I worry a little bit about legislative language that sets a requirement on the physician prior to prescribing without having any specification of performance of the system. That is to say, if the system is down or if there's a 15-minute lag in response, it becomes a factor which interferes with the ability of that physician to care for the patient. So if we could work with the author to assure that there's language that frees the physician of liability from day to day if the cure system is not functioning as performed, that would be helpful.
Thank you. Dr. Levine?
Yeah, just a question. The original version of the bill was a mandate on physicians and pharmacists to check cures before prescribing and dispensing. And the most recent version, the pharmacist requirement was eliminated. Do you know, can you explain that?
I believe that amendment was taken in committee, so I don't kind of know the discussions. I know some of the concerns that were raised in the committee analysis by dispensers were basically that they would be dispensing at a higher volume than prescribers, but I can't speak to the fact of why that amendment was taken, but that was some of the concerns that was raised in the analysis. So,
Ms. Shipsky?
That was going to be my question, because I think we had originally talked some time ago when this whole issue came up about requiring the dispensers to be as equally as responsible and also kind of be a backstop, perhaps if for some reason the physician office, they could not access it. And for pharmacists to object to that, they call the doctor's offices all the time to check on prescriptions or, whatever. So I would hope that perhaps maybe this board could take a position that we would encourage the inclusion of pharmacists, dispensers in this. And that, my first point. My second point is it said that the CMA objected to the bill. Do we know on what basis?
I'm sorry, what was that?
It said, when I'm reading the oppositions, it was all supported by all the labor unions, but it was objected to by the CMA. Do we know what?
I think probably CMA will come up and talk to this one. Is it okay if the author's office kind of responds to the question on the dispensers? Okay. Thank you.
The pharmacists already have to use the system. That's the reason why they were taken out, and that they already report what they're dispensing.
They do.
That's not in real time, is it? That's a concern, that if it's not in real time, the patient's long gone, and it doesn't provide any real immediate oversight.
Dr. Lewis?
See, again, the issue is the real time. We had discussed this in several previous board meetings, and I mean, I think the concept here is fine. It's a consumer protection. I think that's paramount. But if you're in an emergency department, or you're like what Dr. Krause is alluding to, unless you can get real time, there's such a delay in the administration of treatment that I could see that would be a big roadblock. So I don't know where it is in amendments or what because it says here that the bill would further specify the requirement in this bill are not operative until DOJ certifies it is working. And I just want to know whether that is working is real-time working. So it's my only suggestion. But the concept is good.
I think, are there any additional comments?
I have a question. Oh, sorry.
Doctor, and then Ms. Jaroslawski.
Yeah, I think I support the concept. That's not even an issue. I think QS database is needed. It should be looked at, but putting it into practice is my concern. That is that it's not real time. Often it takes forever to get through there to really. So we need to really make sure that it works. Before retrospectively going back and say, oh, by the way, this doctor or this, especially this ER doc, did not look at or did not have the information. I think we can correct all the issues, including real time, both for pharmacist and the doctor looking at. If we can do that all, I don't have any issues. I think it's a great idea, but we do need to make sure that it's done right, rather than just done just to satisfy the public fervor.
Okay. Ms. Kirkmeyer, can you comment on a few of the members' observations?
Yeah, just on two things. First of all, on the real time, the law authorizes the prescribers to have 7 days to enter the data in the system. Until that law is changed, it will remain that. But I believe even at 7 days, from some of the information that has been received, that still is beneficial enough. If you use the system, you would be able to see a physician or a patient who is doctor shopping if they've gone to multiple physicians. At least you'd still be able to see that. You wouldn't be able if they hadn't entered it in the last 7 days, but I think over time and over history, I think that would be beneficial for the physician to review it. One thing in regards to Dr. Krause's comment, I did want to read the language of Section C that states, notwithstanding any other law, a prescriber is not in violation of this section during any period of time in which the CARES database is suspended or not accessible, or any period of time in which the internet is not operational. So they have covered that in the bill, so I wanted to let you know that.
Thank you.
Ms. Jaroslawski, and then Dr. Levine.
I just wanted a clarification.
Oh, sure.
Kim, the statute says before. The language in the bill says before prescribing, right? Mm-hmm. Before prescribing is not 7 days after or 6 days after.
No, for physicians, you would have to check it before prescribing. Once what I'm talking about for the 7 days for as a pharmacist, when they dispense a drug, they have 7 days to enter that information into the CARES system.
No, I understand that, but in terms of interdicting a prescription that shouldn't be dispensed and filled 6 days later, entering the information isn't necessarily, I think, what was intended, which was a belt and suspenders approach. The doctor's office is in an area where the internet, a telephone pole fell down and there's no connection to the internet, patient goes to the pharmacy. I think the idea was a belt and suspenders, that prior to the patient leaving with a bottle of Vicodin or OxyContin, there would be 2 opportunities to check. So the reporting issue is not the issue. It's the checking.
They're checking,
on
yeah.
the patient's history.
Yeah, and unfortunately, we can't really comment on why the dispensers got taken out.
Sure, I appreciate that.
Ms. Yaroslavsky?
So excuse me, I just wanted a point of clarification that it's for the first time a doctor prescribes, and then on an annual basis for these specific scheduled drugs. But at the same time, what I heard, I thought, was an opportunity for education for the patient, for the broader patient base at the same time. Is that correct? That while, how is it that doctors are going to notify patients that they're going to do this? And is there an opportunity at that point to maybe take a look at a broader educational opportunity? I think I'm fine with the bill, the language and all that. I'm just saying that maybe we have some unintended opportunities that we should be taking a look at through this legislation.
I think it's incumbent on all of us, and as this bill proceeds, to educate prescribers, physicians, and patients, law enforcement, all the stakeholders of their role in this process. I'll go to Dr. Balot. Thank you.
Hi. Okay. I have a question, and I wanted to ask, so that the bill is very important for sure. In terms of how the system could monitor and track and be able to identify whether or not a physician or a prescriber, I presume, not just a physician, would in fact at 1 p.m. check the cures and write a prescription at 1:10, not sure how that would be monitored. But let's say that somehow there's some type of monitoring, if that was the intent. But more broadly, because I use Cures all the time, and I think it's an extraordinarily important tool, is there going to be, or is there an intent to be able to provide information back at a population health level so that as we are able to see there's actual patterns that you have to train physicians or prescribers to look at, because you can start to see the quote-unquote doctor shopping, but it's not always just the right-hand column with the name of the physicians or prescribers, but it's also looking at the quantities, the combinations thereof of the medication. So is there anything that's going to be in this bill for monitoring or providing population health data?
That's actually more a question of how the updated Cure system is going to work, so I'm not sure the author's office can answer that. I mean, as far as regulation, the board would be responsible for regulating this bill. So basically, if we were to get a complaint, and we would check to see, did the patient make a note in their records that they checked the system before they prescribed? So that's how it would be regulated. But as far as the Cures and what kind of like reports and stuff it can put out, that's probably a better question for Department of Justice, I guess.
So the new system is going to have all of the information. If you go in and run a query on that patient, it'll have all of that information, as well as the new system is also supposed to have the contact information for those other physicians. I think right now it only has name of those other physicians, and it's going to be adding the contact information. Hopefully that answers your question.
Dr. Yep.
I think the concept is good. I think we all agree we should monitor closely. Just want to share my own experience about implementing this whole thing. Everybody needs to think hard. I have 2 patients that I wrote prescription of Norco after kidney stone surgery, and my aim wasn't that good, so instead of 2014, I kind of put 5 and make it real clear. The pharmacy refused to fill that, and my patient in Van Nuys, which is 40 minutes away, couldn't get a justified paramedic field because that strict mentality around all these controlled substances now. When we're doing more and more requirement, we need to think out what are the ways to do it such that we're not over-regulated. We're hurting patients who didn't need it, try to screen out a few patients who over-abuse it. And there's also a patient who live in Inglewood, come to my office downtown. The pharmacy would not fill his Norco because he said, you're from out of the area, and we don't know this is legitimate. And then the patient cannot get those filled. Again, justified prescriptions. So I think we need to look at all the angles with the help of the pharmacists.
I think the experiences you're hearing from physicians who are dealing with and treating patients every day of their career is incredibly valuable for the senator. Let me try to, I'll not do a good job at it, but I will try to summarize the board members' views on this. One is support of SB 482, and then I'll finish. Support support staff's recommendation, with the observations and comments that there are issues around the operational aspects and the Department of Justice's certification of the Cures database, that it is truly up and running. We share the observation and perhaps concern that IT systems have a life of their own, and there are those unintended consequences. We would also like the legislative record to reflect some, and the DOJ certification, those issues. There's language in the bill, but I think it would be enhanced if the legislative record had some guidance around that. So if there's any interpretation questions, we have the benefit of the medical board's observations.
Is there going to be a motion?
Well, that's where I'll see where that goes.
So I would make the motion as you stated it.
Dr. Levine?
Yeah, and in terms of, also I'd like to add to that, re-looking at the issue of optometrists, of pharmacists checking cures prior to dispensing a C2 or C3.
I've asked our executive director to try to summarize what I said in response to Ms. Webb's question.
So I think we're looking at a support, if amended, to include further definition on what it means to have the care system up and running, registration, that it is coming through as an approved system that is available for them, including then also looking at trying to get an amendment to have the dispensers added back in, adding on Dr. Levine's.
Is there a motion?
So moved.
Moved by Dr. Lewis. Is there a second? Second by Ms. Yaroslawski. We're going to take public comment for sure. Absolutely. Absolutely. And I have speaker slips, but I wanted to get through that process so the speakers understand what's before them. The first speaker card I have is from Jody Barber. And if Jody, hi. Good afternoon.
Good afternoon. Thank you for having me today. This is my son, Jared. And he's also on that poster as well. He's on the top row with all his friends. Those boys passed away from an overdose in 2010, and we all went to the same high school. I live in South Orange County. A once beautiful, happy place to live has turned into a place of sadness and grief for hundreds of families. I lost my 19-year-old son, Judd, and 3 of his friends from an overdose in 2010. They all had Opana in their system. My husband and I discovered our son sitting on the couch at 3 a.m., barely breathing, in a drug-induced coma. Jared's friends were overprescribed 90 Opana and 90 Vicodin over and over again. I soon heard of several more deaths in the same year. From 2007 to 2010, there were 80 accidental overdoses from opiates from the ages of 18 to 24. And in 2012, the death toll jumped to 188. Drugs such as OxyContin, Opana, and Vicodin are increasingly being used and sold, and often with deadly consequences. Opiates are easily accessible because doctors do not regulate them as closely as they should. And many teens can find painkillers and other medications in their own medicine cabinets. Painkillers like OxyContin, Vicodin, and Opana are the main drugs cycling through the community. Opiate addiction is the worst drug epidemic in the United States history. Emergency room visits for prescription painkiller overdoses have doubled during the past 5 years to nearly 500,000. The only way to fight the disease-like spread of drug abuse is to regulate prescriptions prescribed by doctors. Jared and his friends loved life. They played sports, and a couple of them had injuries and were overprescribed Vicodin. Mandatory use of cures is important because my son's death and the thousands of other young lives taken too soon were preventable. Furthermore, cures will help deter the RX drug dealers on the streets and prevent doctor shopping. Thank you.
The next speaker card I have is Carmen Balber. Carmen, hello. With the Consumer Watchdog.
Thank you. Carmen Balber. I'm the Executive Director of Consumer Watchdog and also here to support SB 482 and urge the medical board to support it. You went over a lot of what I wanted to point out, so I think I just want to pull out a few facts from the legislation, make sure it's clear. Number one, not only does the legislation say if the database is for some reason unoperational, a doctor has fulfilled their duty by trying to check it, it also says that the bill does not take effect until DOJ certifies that Cures is operational for statewide use. No one really went into a lot of detail, and we don't have all of the detail yet, but the Department of Justice has twice in the last 2 months testified to the Assembly and the Senate that Cures 2.0, which is a complete upgrade of the system, which should allow 200,000 prescribers in the state to enroll actual real-time access, because I know you mentioned it's sometimes hard to get to now, should be completed by the end of next month, so by the end of June. So far before this bill actually makes its way entirely through the legislative process, Cures 2.0 should be up and running, and you should have a chance to check it out. I think maybe the last thing I just will note, since I didn't hear it, was the success of mandatory use in other states. California, which was the first state to create one of these prescription drug collection programs, the prescription database back in the 30s, is now falling behind. Many other states have begun to require doctors to check as well. And in those states, we've seen up to a 75% drop in doctor shopping and up to a 10% reduction in opioid prescribing. And I just want to give you a few stats from Tennessee, where just in February they put out a report surveying doctors who use the system, where I will mention that the medical society there was opposed to requiring doctors to use their prescription drug database when it was proposed, but now that it's been in effect for a few years, 41% of prescribers say they're less likely to prescribe controlled substances after they check the database. 34% say they're more likely to refer patients to substance abuse treatment. And 86% of doctors report that it's a useful tool. It helps them decrease doctor shopping. So this is a tool, this is as simple as requiring doctors to look at a patient's medical record before prescribing these dangerous addictive drugs. Well, we urge your support.
The next speaker card I have is for Julie D'Angelo Felmuth, the Center for Public Interest Law. Hello.
Good afternoon.
Julie D'Angelo Felmuth from the Center for Public Interest Law. For the benefit of the new members, CPIL is an academic and advocacy organization based at the University of San Diego School of Law, and for 35 years we have been monitoring boards and commissions that regulate professions and trades, including the medical board. As you know, your statutory mandate as medical board members is protection of the public, and where protection of the public is inconsistent with some other interest sought to be promoted, protection of the public is paramount. As this board knows, as you discussed, the new version of Cures is scheduled to roll out in July. All prescribers and dispensers are already required to register with the new Cures system by January 1, 2016. It makes no sense to surcharge the license fees of every prescriber and every dispenser, which has already been done, and to earmark those funds to overhaul and rebuild and maintain Cures so that it is usable, and then to require all prescribers and dispensers to register with it, unless prescribers are also required to check with it prior to prescribing an addictive controlled substance to patients who are possibly addicts and who are possibly doctor shopping. The burden imposed on doctors in this bill is minimal. One check prior to prescribing such a drug and annually thereafter. That burden is nothing compared to the epidemic of prescription drug addiction and prescription drug overdose deaths that are occurring now in the absence of this requirement. This bill does not legislate the practice of medicine, as some doctors' organizations have argued. It does not prohibit prescribers from prescribing any drug. It simply requires a prescriber to check first to determine that that patient is not doctor shopping and does not have multiple duplicative controlled substances, prescriptions, and prescribers. We urge your support for SB 482. Thank you.
Thank you. The next speaker card is from Yvonne Chung.
Good afternoon, Yvonne Chung with the California Medical Association. We are in opposition to this bill. We believe that this bill is premature and it really runs counter to the good work that the board has been doing related to prescription drug abuse. Physicians have joined you in working to create strong prescribing guidelines. We've supported Cures both in concept and financially. We've been at the table, and what we've always said and will continue to say is that if you build it, they will come. And when the Cures system works for clinicians, we believe that clinicians will use it. There's already some suggestion that this is already occurring. The number of registrations has increased substantially. The number of patient activity reports being requested has increased substantially. So even under the current outdated system, physicians who are not required to use it are using the system. Our concerns echo a lot of the concerns that were voiced by the board members with regard to the issue of the bill being bill's implementation being contingent upon certification of the system by DOJ. We don't believe that's enough. I think this board knows as well as we do that state IT systems, Breeze, DOJ, there are times when the entity that is creating the system declares that it's fine and the users would probably differ. So we believe there needs to be some kind of third-party verification from either professional boards or the medical board, somebody who's actually using the system saying that the system actually works. We also take issue with the legitimate use language. We believe that this creates a really subjective standard and that the impact of this bill is really going to be on patients that we believe that really do have legitimate pain needs, but this basically creates a chilling effect for physicians not to prescribe to them in order to err on the side of caution. So once again, we urge your opposition of this bill. It sounds like the board members have the same concerns that we do, but we believe that those concerns are substantial enough and the board should put some teeth into their recommendation and oppose the bill so that these amendments can be made. Thank you.
Thank you for your comments. I have no additional speaker cards from the public present. Are there anybody else that wishes to speak? If not, I'll now go to the telephone. Are there any members of the public on the telephone that wish to comment?
Yes. Yes, hi. Hello?
Yes.
Can you hear me?
I can.
Okay. Hi, my name is James Kennedy, and I'm calling, first of all, to implore the medical board and its members to support SB 482 The reason for that is I'm a parent of a young man who passed away from a prescription drug overdose that was prescribed to him by an unscrupulous doctor on the 4th of February of 2010. They found him laying face down on the side of the road. He was dumped there by the people he was with the empty prescription bottles by his side. And my wife and I have been very active in trying to combat this epidemic that we have of prescription drugs. And we were instrumental in helping getting the Good Samaritan bill passed. We were instrumental in doing a lot of things to help addicts to find recovery, and we still do that. But we want you to understand how important it is for the doctors to realize that the majority of the membership of your group or your board or your association are legitimate, law-abiding doctors. But unfortunately, there's always going to be a percentage who are not, and that was the case with the doctor who prescribed my son. I put a complaint into the medical board, and I'd like to applaud the medical board for investigating it. And just about 6 months ago, they had the doctor voluntarily surrender his license so he can't practice or prescribe or kill young people anymore. I absolutely know that this is an epidemic, and I know that it is your responsibility to do no harm. And as long as you have doctors out there who are willing to prescribe for profit versus for healing, then I think we need to have this cures bill implemented, and I think that the doctors should participate in it to make it better, because people's lives are at stake and people's lives will be saved. Thank you.
Thank you, Mr. Kennedy, for your comments and testimony. It's appreciated. Are there other members from the public on teleconference that would wish to speak?
Not at this time.
Thank you. That closes public testimony in SB 482. There's been a motion and a second. Ms. Tooth, please call the roll.
Dr. Bolot?
Support the bill.
Okay. Dr. Bishop?
May I ask for a restatement of the motion for, just so I understand?
Certainly.
I believe I'm in favor. I just want to make sure.
Sure, absolutely. It's a good idea.
Once was enough, Dr. Bishop. I believe that it's support if amended to put some requirements around what it looks like for the system to be registered to be working, in addition to adding in dispensers as being required to check the system as well.
Important concept.
That was it, yeah.
Okay. I was like, okay.
Aye.
Dr. Gonadev?
Aye.
Dr. Hawkins?
Support.
Dr. Kraus?
Aye.
Dr. Levine?
Aye.
Dr. Lewis?
Yes.
Dr. Yip?
Aye.
Ms. Pines?
Aye.
Ms. Shipsky?
Aye.
Ms. Wright?
Aye.
Ms. Yaroslavsky?
Aye.
Mr. Serrano Sewell?
Aye. The motion carries. That was a great discussion, colleagues, and I think I know it's the right thing to do. Can we move on to the next?
Moving on. So I just want to provide a quick update on the board-sponsored bills, and those are the ones in pink on your tracker list. The board had some language that it supported, or sponsored, related to accredited outpatient settings. What happened is that the board's language was put into SB 396 along with some other language that's actually sponsored by the California Ambulatory Surgery Association. So we aren't sponsors of the whole bill, but we basically are strong supporters of our language. And this is the bill that would require peer review evaluations for physicians working in accredited outpatient settings. It would require data reporting, and it would require unannounced inspections. And so that's the board's piece of that bill. The part that's sponsored by the California Ambulatory Surgery Association would allow licensure by California Department of Public Health for surgical clinics or accredited outpatient settings. They would also have to be certified in order to be licensed, Medicare certified. And then the other part that's sponsored by CASA would allow accredited and certified outpatient settings access to the 805 report information, and that was kind of an outlier of that CAPIN decision. And so those are the two parts. So we're kind of working with CASA to be strong supporters, but neither one of us is really sponsoring it, so it's kind of a weird situation. But I just wanted to provide an update on that bill. And so we don't have to vote again because we've already voted to sponsor our provisions. So if no one has any questions, I'll just move on to the next one.
No
Any
questions?
Public comment?
Public comment? Seeing no public comment, or are they comment from? Oh, hello. Sorry. Please.
Yvonne Chung with the California Medical Association. CMA has an opposed unless amended position on SB 396. We appreciate the author and the board being willing to work with us on this issue. Our issues arise out of concern that some of the changes proposed could have different impacts on a facility depending on its structure, with unclear improvements on patient safety. Since outpatient surgery settings run the gamut from small single physician offices to larger facilities with multiple clinicians, we believe that changes to the regulatory structure could have decidedly different impacts on a facility depending on its size and structure. The bill's been amended to address our major concerns with the peer review language, but we continue to have outstanding concerns with the requirements for unannounced inspections and the data collection issue. Regarding the data collection requirements, we know that the requirement was not discussed at the board's OSS task force work leading up to the bill, and we've heard the board's desire for additional data, but it's unclear what questions the board is trying to answer. And the reporting requirement would place both administrative and financial burdens on facilities, and we believe there needs to be more clarity about what the board is trying to achieve before we impose these requirements on facilities. Thank you.
Thank you. Are there additional public comments from the members, from the public present? Any comments from the telephone?
Do you have any comments on the line?
Not at this time.
Thank you.
Thank you.
Okay. Moving on to SB 408, this is the bill that would basically define midwife assistants and put parameters on what kind of services they can provide. This bill basically made it through the Policy Committee and Appropriations Committee, no votes, and so it's just on Senate third reading. It's going to be amended to add certified nurse midwives as supervisors. This is something that the Certified Nurse Midwife Association requested, and no one had any issues, so we are going to, the author is going to amend them into the bill, and so that's my update on that. Second public comment, I guess.
Are there any comments from the board? I see none. Any comments from the public? I see none. Any comments from the phone?
None at this time.
Thank you.
Okay, moving on. SB 800 is the Health Omnibus Bill. And so this bill includes all the board's technical and clarifying changes. A lot of the changes are related to making it clear that the board has the authority to take actions related to putting other license types, not physicians and surgeons, on probation, allowing for reinstatement. So a lot of the stuff is just to clarify the board's authority. So this bill has moved through just fine, and it's in appropriations as well. And so that's my update on that.
Thank you. Public comment? Seeing none, any comment from the phone?
Not at this time.
Thank you.
Okay, moving on to the first bill in green. This is AB 34, Bonta and Jones Sawyer. This is one of the bills related to marijuana, and there's going to be several in this presentation. A lot of them kind of mirror each other. This bill is very similar to AB 26, which the board voted to support at the last meeting, and it looks like AB 26 has kind of merged into this one because now the author of AB 26 is now one of the co-authors on this bill. So it looks like this AB 34 is the bill that will be moving forward. Basically, the provisions that impact the board are almost the same. The only big difference is, so it adds it to the board's priorities. It adds recommendations for marijuana for medical purposes to Business and Professions Code 2242 for prescribing. The only thing that it differs from AB 26 on is it doesn't require the in-person examination. So it requires that an appropriate prior exam be done, but it does not require that be in person. The rest of it is basically the same. So it has some advertising issues in there. It has the priority and then the prescribing requirements. So it's very similar to the bill we supported before. The only thing, like I said, that differs is the in-person part of the exam. So board staff is suggesting that the board support this bill like it did AB 26.
I don't know that we've ever polled the board, but I've spoken previously about my concerns about in-person examinations. And if that's going to go away as 26 transforms into 34, it concerns me. Most of the time when people seek a physician, it's either because they're ill, in pain, or worried that they may be ill and they're seeking an examination. In the case of opioid drugs or marijuana, very often people seek a physician as a way to get the recreational drug that they desire, not necessarily for medical evaluation. In that we now have telehealth, I have nightmares about marijuana recommendation boiler rooms where a dozen physicians sit in a windowless office in a basement Skyping marijuana recommendations around the state. And I think that would be a terrible thing. So although we may need to poll the board, I would be in favor of continuing to ask for in-person examinations for marijuana recommendations.
I can just give you a little background. It's very difficult to get the in-person to stay in because organizations, and I don't want to call anyone out, but I know it's something that California Medical Association has asked to be removed. And so I know it's very important for us. We, as board staff, have concerns. We think it should really be included in 2242 because right now it doesn't expressly say that appropriate prior exam. So we're happy with that part, that at least it's in 2242. I did let the author's office know that we supported AB 26 that had the in-person, but there's concerns from other parties, and so that's why the in-person was removed last year and why it's gotten removed this year. I mean, there are certain laws on the books already related to telehealth. So you have 2290.5, which has to be followed no matter what, whether it's related to marijuana for medical purposes or whether it's related to anything. But that's kind of just some background on the reason why the in-person is being pulled out.
Doesn't stay in there. I'm going to go to Ms. Yaroslawski, then Ms. Wright.
I would like to echo Dr. Krause's concerns. We've tried so hard to make it that the recommendation of marijuana for medicinal use should be no different than the recommendation from the prescription a doctor would put out for antibiotics, for example. And in order to get antibiotics, you normally have to have an in-person exam. I'm not saying that they're the same, okay? I'm just suggesting that as we go forward, I would like to see if we can't, we may not get there, and this may be all we can get, but at least that we should be at the table suggesting that in-person exam means in-person, a good faith exam in-person is what it means.
Well, an in-person kind of makes it different than anything else. So right now it's just appropriate prior exam. So it's up to the physician and the standard of care on if that appropriate exam is in-person or not. So in-person for just marijuana does call it out a little bit differently than everything else. But, you know,
so currently a patient can go to a doctor or not go to a doctor and have a prescription written for an antibiotic without having a good faith exam?
If it's an appropriate prior exam pursuant to the standard of care. So that's what this all is being based on.
Okay, Ms. Wright?
I just have a couple questions about AB 26 versus AB 34. I see that AB 26, there was no support and or opposition. There's none. And now there's a whole host of support versus opposition. Do we have sort of general idea of which group and what they opposed and why?
So AB 26 kind of started, there was 4 bills in the legislature that all dealt with marijuana for medical reasons. AB 26 started first, and 2 members kind of introduced the same kind of bill. What happened is it didn't get to the point of a committee hearing really because then the authors decided to go together on AB 34. The reason why you see so many law enforcement people kind of in opposition is because law enforcement is kind of going for the other set of bills that we're going to go through next. So in the past, there's been a couple different, like this is also very similar to the Amiano bill from a couple years ago. But then you have another bill that was sponsored by law enforcement, and that's what the next couple bills kind of mirror. And so you kind of have 2 camps, and that's why you'll see a lot of law enforcement in support of one, and they're kind of picking one. So
it's not legitimate opposition. It's just this is not our bill. So
well, I mean, I'm not going to say that it's not legitimate, but that's,
I mean, I said it. So I mean, that's why I'm asking.
Yeah.
Okay.
Yeah.
Okay.
So that's kind of why you have to. And this is just basically carries over from the last couple of years of the types of bills that we've seen out there.
Thank you.
Thank you.
Doctor, and then I'll go to Dr. Lewis.
Yeah, the appropriate exam is, I think it's there for everything we agree on telemedicine. But I do have concern like Dr. Cross expressed, that is that this is one place somebody might be sitting on. I mean, as after going through for 3 years disciplinary actions on some of these doctors, they get paid a small amount to sit in a room and prescribe. And it worries me that that might, this way they might not even go there. They might just be on the Skype or video chat or even on telephone. Telemedicine is including telephone. And then we have to struggle with what was the appropriate exam. So that's where my concern is. But I totally understand you can't just put marijuana only in person, but take out, but everything else is an appropriate exam for telemedicine. So,
Dr. Lewis?
I'm not sure if it's the job of the medical board to sort of police or dissuade the storefront marijuana dispensaries. I think our job is to make sure that physicians practice appropriately and take care of patients. And with that, an appropriate prior examination is what our standard is. And I think that if we start to get into areas where we're going to require a in-person for this subject, and then all of a sudden it's going to creep over to, okay, now we need an in-person for, let's say, this kind of drug, I think we're going to sort of defeat the whole purpose of delivering health care to the masses. So again, I don't think we should be able to be responsible to police what is out there in the community or the storefronts. In addition, I thought at the last, and Ms. Kirschmeyer, can you help me jog my memory, at the last meeting or so, or we had the marijuana task force, we talked about our policy was an appropriate prior examination, and now we're sort of switching back to like, oh, wait a minute, let's think about this. So can you help me with that, please?
Yeah, when we held the marijuana task force, we looked at AB 26 at the time that had already come out. And so that's why we had voted to support it at that point. And then we said that if the in-person does get taken out, that's something we'll have to look at again and possibly go forward in the future.
Okay. I'd like to make a motion to support AB 34.
Is there a second?
Second.
Any public comment to the motion? Support AB 34? Any public comment from the telephone?
Not at this time.
Thank you. Ms. Toof, please call the roll.
Dr. Bolat?
Abstain, please.
Dr. Bishop?
Aye.
Dr. Gonadev?
abstain.
Dr. Hawkins? Dr. Kraus?
Abstain.
Dr. Levine?
Support.
Dr. Lewis? Dr. Yip?
Abstain.
Ms. Pines?
Abstain.
Ms. Shipsky?
No. Oppose.
Ms. Wright?
Abstain.
Ms. Yaroslavsky?
This is exciting.
No, because I'm conflicted. so I
Vote your
apologize.
conscience, of course.
Pardon me?
Vote your
I'm going to abstain.
Thank you.
And Mr. Serrano Sewell?
Aye. Can you please call the vote count when you're prepared and ready?
We have 7 abstain, 1 oppose, and 5 for. 5 support.
Do abstains count towards the total vote count? I mean, for purposes of passage, I'm not as well versed on my Robert's rules.
You need a majority to pass.
You need a majority, so that would be 8.
Okay. All right. Motion fails. Is there a substitute motion? Dr. Kraus?
I know it's politically not viable, but I would propose that we support 34 if amended to include an in-person examination, and I would like to speak to that.
Okay, you may speak to it.
You know, we're not inventing things out of the air here. The federal government, the Drug Enforcement Administration, requires in-person examinations for certain classes of opioid drugs. The federal government has no rules for prescribing marijuana because the federal government doesn't view that as a drug which can be prescribed. And I think that we, in our efforts for consumer protection, have an interest in ease of access to drugs which can be abused. And just as we have great concern over ease of access to opioid drugs, we should have concern about ease of access to marijuana. And the in-person examination is one methodology of having greater assurance that the public is well served for receipt of marijuana recommendations. That's the motivation for my motion.
Is there a second?
Second.
Second. Discussion on the motion? I think Dr. Levine?
I just want to point out that I think there's a difference between an appropriate exam and an in-person visit. And there's an awful lot of in-person visits that result in recommendations for marijuana that have nothing to do with an exam of any kind. So it's not a guarantee by any means that the right thing will be done.
Surely.
That I share that same observation and concern. We do have a second from Dr. Yip, and we're having discussion on the motion. Are there any additional comments from the members? Seeing none, I'll go to the public. No comments. Telephone?
None at this time.
Thank you.
Ms. Toof, can you please call the roll?
Dr. Bolat?
To the motion, aye.
Dr. Bishop?
Aye.
Dr. Gonadev?
Aye.
Dr. Hawkins? Dr. Kraus?
Aye.
Dr. Levine?
Aye.
Dr. Lewis? Dr. Yip?
Aye.
Ms. Pines?
Aye.
Ms. Shipsky?
Aye.
Ms. Wright?
Aye.
Ms. Yaroslavsky?
Aye.
Mr. Serrano-Sewell?
No. Motion carries. Next item?
Okay, the next item are actually two bills that are basically the same, AB 266 and SB 643. These are bills that both relate to medical or marijuana for medical purposes, and this is similar to the CREA bill from last year that the board took a neutral position on. So this would add marijuana cases to the board's investigative priorities. It would not add it to 2242. It would prohibit a physician from recommending medical marijuana unless the person is the patient's attending physician. Both bills would subject physicians recommending medical marijuana to the definition of financial interest in Business and Professions Code 650.01. And lastly, these bills would require the board to consult with the Center for Medicinal Cannabis Research when we develop and adopt medical guidelines for the appropriate administration and use of marijuana. When we heard this last time, we basically took a neutral position because it didn't give us as many enforcement tools because it didn't include it in 2242, but we were neutral. So the board is suggesting that we be neutral on both these bills as well.
So you want, so moved.
Dr. Levine made the motion, seconded by Ms. Yaroslavsky. Are there comments from the members? Seeing none, are there any comments from the public? None? Any comments from the phone?
Not at this time.
Thank you.
Thank you. Ms. Toof?
Dr. Bolat?
Aye.
Dr. Bishop?
Aye.
Dr. Gonadev?
Aye.
Dr. Hawkins? Dr. Kraus?
Aye.
Dr. Levine?
Aye.
Dr. Lewis? Dr. Yip?
Aye.
Ms. Pines?
Aye.
Ms. Shipsky?
Aye.
Ms. Wright?
Aye.
Ms. Yaroslavsky?
Aye.
Mr. Serrano-Sewell? Thank you.
Motion carries.
Okay, next bill, AB 483. This is a bill that was actually a bill from last year, and it's been reintroduced, and it requires all boards, including the medical board, to prorate the initial licensing fees. The purpose of this is to basically make sure that licensees aren't overcharged, that they get their full 2 years of license or full time of license. The board staff has some concerns with the prorating, basically it would result in delays for licensees. So once they get all their licensing application complete, instead of issuing a license, board staff would then have to prorate the fee, go back to the licensee and say, okay, this is your fee. So it just adds some steps to the process. And we've been in conversations with the author's office, and there's actually another bill out there that we'll go over in a little bit, AB 783, that would actually just allow for a straight 2-year license for the psychology board. And so we've kind of talked to both authors' offices and hoping that we can be added to the straight 2-year license bill. We've talked to Patterson's office, and they're okay with removing us from this bill as long as we get added to the straight 2-year license bill. So at this point, staff is recommending a neutral position if it's amended to remove the medical board.
Thank you. Is there a motion?
I move.
It's been moved and seconded. Dr. Lewis and Mrs. Jaroslawski. Are there any comments from the board? None? Seeing none, are there any comments from the public? Any comments from the phone?
None at this time.
Thank you. Ms. Toof?
Excuse me, Dr. Bolat?
Aye.
Dr. Bishop?
Aye.
Dr. Gonadev?
Aye.
Dr. Hawkins? Aye. Dr. Kraus?
Aye.
Dr. Levine?
Aye.
Dr. Lewis? Dr. Yip?
Aye.
Ms. Pines?
Aye.
Ms. Shipsky?
Aye.
Ms. Wright? Sorry. Ms. Jaroslawski?
Aye.
Mr. Serrano Sewell?
Aye. Motion carries.
Okay. Next bill, AB 637 Campos. This bill would allow nurse practitioners and physician assistants under physician supervision to sign physician orders for life-sustaining treatment forms. Allowing NPs and PAs who are under the supervision of physician seems to be a reasonable expansion and one that will help to improve patient care. NPs and PAs are already involved in providing end-of-life care to patients in California, so it makes sense to allow them to sign off on the POST forms to ensure that patients have better access to providers who can assist in establishing end-of-life care orders. Board staff is recommending that the board support this bill.
It's been moved and seconded. Dr. Lewis and Dr. Yip, are there comments from the board? Seeing none, are there any comments from the public? Yes. Hello. And did you fill out a speaker card? And
I did, but
oh, it's okay. All right.
Can you add that to it? Teresa Anderson, California Academy of Physician Assistants. We are in support, and it's important to our members. This has come back a few times, so we do support this and ask for yours as well.
Thank you. Are there additional comments? Are there any comments from the telephone?
Not at this time.
Thank you.
All right. Ms. Toof, please call the roll.
Dr. Bolat?
Aye.
Dr. Bishop?
Aye.
Dr. Gonadev?
Aye.
Dr. Hawkins? Dr. Kraus?
Aye.
Dr. Levine?
Aye.
Dr. Lewis? Dr. Yip?
Aye.
Ms. Pines?
Aye.
Ms. Shipsky?
Aye.
Ms. Wright? Ms. Jaroslawski?
Aye.
Mr. Serrano Sewell?
Motion carries.
Great. Okay, next bill, AB 684. This is one of the bills that's in your update packet. This bill would place a moratorium on discipline for registered dispensing opticians or optometrists by the board or the California Board of Optometry for engaging in any business relationship currently prohibited in Business and Professions Code. This bill would take effect immediately because it contains an urgency clause. For a little background on this issue, AB 595, Alejo, was introduced this year and was a result of numerous meetings between the National Association of Optometrists and Opticians, the California Optometric Association, and other optical stakeholders, including the medical board. AB 595 would have changed the business model of registered dispensing opticians in California, and they included protections for an optometrist's clinical judgment to address concerns that RDO would influence or interfere with the clinical decision of an optometrist. Although many meetings were held on this issue before the bill was introduced, some stakeholders still had concerns that could not be resolved in time for the bill to be heard by Assembly Business and Professions Committee. And so what happened is BNP is basically going to work on this issue. It's the beginning of a 2-year session, so we basically have 2 years. But what they, Assemblyman Bonilla basically amended this bill to allow these time for these discussions to happen. And in the meantime, so these business arrangements aren't disciplined while these discussions are going on. And so the board is an active stakeholder, and we're suggesting that the board take a neutral, if amended, position. We think that The moratorium just needs a little technical work to make sure that it's not too broad where like new RDOs can come in and not get disciplined. So we will be working with the various stakeholders. So at this time, we're suggesting a neutral if amended position.
So move.
Dr. Kraus made the motion. Is there a second? Second, Dr. Levine. Thank you. A discussion from the members? Seeing none. Is there any comments from the public? I see none. Any comments from the phone?
None at this time.
Thank you.
Please call the roll.
Dr. Bolat?
Abstain.
Dr. Bishop?
Aye.
Dr. Gonadev?
Aye.
Dr. Hawkins?
Aye.
Dr. Kraus?
Aye.
Dr. Levine?
Aye.
Dr. Lewis? Dr. Yip?
Aye.
Ms. Pines?
Aye.
Ms. Shipsky?
Aye.
Ms. Wright? Ms. Yaroslavsky?
Aye.
Mr. Serrano Sewell?
Aye. Motion carries.
Okay. And the next bill, AB 773 Baker, this is the bill I was talking about a couple moments ago related to the straight 2-year license for licensees. So this bill right now only includes the California Board of Psychology. We've been in discussions with the author's office. They're willing to add us into this bill, and they're just waiting for it to get to the other side. So right now, the board staff is suggesting that the board support this bill if it's amended to include the medical board.
Pardon me. Is there a motion?
I'll make a motion.
Second.
Dr. Lewis made the motion. There's been a second by Dr. Kraus. Is there a comment?
Just clarification, what does the bill do again?
So it basically allows the medical board to do a straight 2-year license. So instead of doing it on the birth year
Got it.
renewal,
This is the
it's
bill we're
straight,
being amended
yeah,
into. Got it.
yes.
Thank you.
Thank you for that clarification. There's a motion and a second. Are there any additional comments or questions from the board? No, seeing none. Are there any comments from the public? No comments from the public. Any comments from the phone?
None at this time.
All right, thank you. Ms. Toof, if you could call the roll.
Dr. Bolat?
Aye.
Dr. Bishop?
Aye.
Dr. Gonadev?
Aye.
Dr. Hawkins?
Aye.
Dr. Kraus?
Aye.
Dr. Levine?
Aye.
Dr. Lewis? Dr. Yip?
Aye.
Ms. Pines?
Aye.
Ms. Shipsky?
Aye.
Ms. Wright?
Aye.
Ms. Yaroslavsky?
Aye.
Mr. Serrato Sewell?
Aye. Motion carries. Thank you. Next
Okay.
bill.
Next bill, AB 890, Ridley Thomas. This bill would enact the Anesthesiologist Assistant Practice Act and would make it unlawful for any person to hold himself or herself out as an anesthesiologist assistant unless he or she meets specified requirements. The bill would require an anesthesiologist assistant, AA, to graduate from a program recognized by the Commission on Accreditation of Allied Health Education Programs or by its successor agency. An AA would also have to hold an active certification by the National Commission on Certification for Anesthesiologist Assistants. This bill would require an AA to work under the direction and supervision of an anesthesiologist, which must be physically present on the premises and immediately available to the AA when medical services are being rendered. The supervising anesthesiologist must oversee the activities of and accept responsibility for the medical services being rendered by an AA. This bill would allow the AA to assist the supervising anesthesiologist in developing and implementing an anesthesia care plan for a patient. In reading through the background, it appears the AAs are highly educated individuals that receive appropriate clinical education and experience to assist anesthesiologists. However, staff does have a concern about the regulatory framework. AAs would not receive a license under this bill. It would basically be a Title Act, so they'd be required to have certification. So there's no direct regulatory oversight on the medical care being provided. If an AA were to provide substandard patient care, there is no license to take disciplinary action against, and there is no way to stop the AA from practicing. Although the bill does charge the supervising anesthesiologist with accepting responsibility for the medical services being rendered, there is not a clear pathway for regulatory oversight of the AA. As such, the board staff is suggesting that board take a neutral position if it is amended to include a framework to stop an AA that is providing substandard care from practicing.
Thank you. Dr. Bishop?
Thank you very much. As you know, I'm an anesthesiologist, and I fully support this bill if amended. But I thought I would, because this is a bill that many people know nothing about, anesthesiology assistants. So I wanted to just give a brief update here, let people know what we're talking about today and why I support it. The nation and the state of California are facing a shortage of healthcare providers. This shortage can potentially have an adverse effect on access to care, especially in underserved areas. This bill, which will allow anesthesiology assistants to practice in California, seeks to provide an additional resource to help alleviate this shortage. Unlike other bills, current and past, this bill does not seek to expand the scope of practice of a certain group of providers. Anesthesiology assistants, like physician assistants, are highly trained, highly skilled healthcare providers and physician extenders who currently are practicing in 17 other states. Like physician assistants, they have a long track record of professionalism and safety working as part of the healthcare team with physician supervision. Their training, experience, and abilities are on par with that of CRNAs, including the attainment of a master's degree. Their program admission requirements include the completion of the MCAT, the same test required for medical school applicants. Their training programs have national accreditation, and they have a national certifying body, including the National Board of Medical Examiners. There's no question as to their skill or value. They also stand ready to immediately enter the workforce once licensed. The Medical Board of California is mandated to provide consumer protection as its highest priority, and there can be no higher component of that mission than ensuring prompt access to care. The board has historically been proactive in this endeavor, working creatively to license additional qualified healthcare providers to allow their practice in California. There is powerful opposition to this bill, and we must consider what might motivate those in opposition. The medical board and state legislature must not become pawns in turf battles between groups. We are here simply to ensure safe and readily accessible health care to the citizens of California. Appropriate concerns, and I want to express again, appropriate concerns have been expressed. The bill in its current state is imperfect, as are many bills when first written. However, the intent of the bill is clear. It simply proposes that the state of California allow a group of highly qualified, immediately available healthcare providers and physician extenders to practice in our state for the benefit of the citizens. I'm confident that the authors and sponsors of this bill will readily amend the bill such that appropriate licensure, supervision, and any other safety concerns will be addressed. The medical board should not give any indication that we intend to less than fully embrace and support safe, cost-effective, improved access to care, and must send a strong message to our legislators. In light of that fact, as I said, I believe that the medical board cannot logically take any position other than support if amended. Thank you.
What is your motion, Doctor?
My motion then would be to support if amended, expressly to consider the concerns that Ms. Samos has expressed with respect to licensure rather than certification.
There's been a motion and a second. Are there any comments from the board? Questions?
I may have missed something. I wasn't sure I understood the distinction. I thought there was a concern about whether there were standards and there was certification. I'm not sure I understand whether we have standards for this group that are clearly agreed upon.
Yeah, so there's requirements that they have to be certified, and so basically this bill says you can't call yourself an anesthesiologist assistant unless you meet these education and certification requirements. So there's already certification requirements out there that are standards, and it's basically just saying in order to call yourself that, you have to meet these requirements, but there's not a licensure requirement by a state body.
Dr. Levine?
So, excuse me. Mike, is what you're saying that there are two paths to equivalent competency, CRNA and anesthesia assistant, and at the end of the training and certification, they have a comparable skill set?
That is a point of contention by the opposition, but I believe that, in fact, the data shows that they are equivalent, basically.
When you say the opposition, you mean people who are opposing this bill. So, Jennifer, you had recommended a neutral if amended. Was there a reason for that?
Not really. It just depends on how strong you want to be. So support with amended would be totally appropriate too. It's just I hadn't heard the discussion yet, so I really didn't know how the board felt about this issue.
Thank you. Ms. Yaroslawski?
Just a question, they will be licensed by someone, correct? And they would be licensed under whose?
They will not be licensed by a state body. So they are certified, and I believe it's a national certification type agency, but there is no state oversight other than oversight of the physician, the supervising anesthesiologist.
Okay, thank you,
Yeah.
thank you.
Dr. Kraus?
But let me just interject. But Barbara, the amendment would be specifically to require state licensure, most likely by us. That's the way it's done in most other states where they are licensed.
Or it could be just some kind, my amendment was basically just some kind of regulatory framework. I wasn't as specific as licensure. That would be a way to get it, but I was trying to leave it a little more open to kind of discussions with the author and the sponsors.
I think that's Dr. Bishop's intent. Dr. Kraus?
Well, I have no overt objection. I'm puzzled as to why we should necessarily support the bill. And even though we may say that it's not a turf battle, there always are turf battles. I don't practice anesthesia, but I practice with a lot of anesthesiologists and CRNAs, and there are some circumstances where CRNAs are supervised by anesthesiologists and other circumstances where CRNAs are supervised by the operating surgeon. But I've sensed in my practice that there always is this friction and perhaps turf battle between CRNAs and anesthesiologists. And now with the anesthesia assistant, we're bringing in somebody who can work in the capacity of a CRNA, but under physician supervision. So I would imagine that the CRNAs would probably object to that. I'm just wondering why we're in the middle of this. I mean, our role should be public safety. And we should want anyone who's going to practice medicine, supervised or not, to be certified and be answerable to some state regulatory body. But why should we support this?
Thank you for your comments. I'm going to go to public comment now, Dr. Kraus, if there's no further comments from the members of the board. I have two speaker cards. I'll start with Dr. Paul Yost.
Hi, thank you for the opportunity to present. I'm Dr. Paul Yost. I'm the president of the California Society of Anesthesiologists. We are the sponsors of this particular bill. I also want to thank you for your service. I know service is a thankless job, so thank you. I'm also a former city councilman from Seal Beach, former mayor of Seal Beach. I served on the CalOptima board for 8 years as well. There's a 2010 RAND survey that shows a shortage of anesthesiologists nationally. California is even worse. When you look at NPI database, California has 18 anesthesia providers per 100,000 population. The rest of the country has 30 anesthesia providers per 100,000 population. We don't have enough providers to provide all the services that we need. There's an increasing demand. Between 2008 and 2013, the population of patients in California over the age of 65 grew by 12.5%. We are continually doing more procedures that require anesthesia. We're now putting an ultrasound on the end of an endoscope, and we're taking biopsies and draining cysts in the pancreas. We're doing that in the lung. We used, in my particular group, I work at Chalk Children's and St. Joseph's of Orange. We used to have 2 travel rooms where we would provide anesthetic services throughout the hospital. We're now up to 7 travel rooms, so we're trying to go various places and cover more that. So we have a shortage of anesthesia providers. We have an increasing demand for anesthesia services in the state of California. Anesthesiologist assistants are highly trained. They have proven to be extremely satisfied, are extremely qualified, excellent providers in 17 other states. They work extremely well, and they are committed to physician-led, team-based care, which is the safest mode of care that you can possibly have. And we support the bill. I would love to have your support if amended. As the sponsors of the bill, we're very happy to work with staff to add any language that they would like. In most states, generally they start with delegatory authority as this particular Title Act goes, and then they move toward licensure at a later time. Many other states are doing the same thing. There are several new anesthesiology assistant schools that are recently opening, one in Wisconsin, one in Colorado. We have been in discussion with many of the academic institutions in California, particularly some of the UCs, to open AA training programs within California as well. So basically there's a shortage. This is a way to help that shortage. We believe in the physician-led, team-based, patient-centered care model, and this moves us in that direction, and that's why we support the bill. We'd love to have your support for it. And I'll answer any questions.
Thank you for your comments, Doctor. Yvonne Chung, CMA.
Yvonne Chung, California Medical Association. We are in support of this bill as well for the reasons that Dr. Yost has stated. We believe that this is a pathway towards having an increased number of allied health providers in anesthesia and anesthesiology practicing under a physician-led, team-based model. And we agree that the medical board should support this bill. Thank you.
Are there additional public comments? Are there any comments from the phone? And then I'll,
Not at this time.
thank you. Ms. Kirkmeyer.
Yes, I would just like to make a clarification and ensure that Dr. Bishop's motion was that it's not just for licensure, it's working with the author's office on some type of regulatory oversight. Absolutely. Thank you.
All right, there's been a motion and a second. Ms. Toof, please call the roll.
Dr. Bolat? Aye. Dr. Bishop?
Aye.
Dr. Ganadev?
Aye.
Dr. Hawkins?
Aye.
Dr. Kraus?
Abstain.
Dr. Levine?
Abstained.
Dr. Lewis? Dr. Yip?
Aye.
Ms. Pines?
Aye.
Ms. Shipsky?
Oppose?
Ms. Wright?
Aye.
Ms. Yaroslavsky?
Aye.
And Mr. Serrano Sewell?
Aye.
I'm going to go back to Dr. Lewis. Thank you.
Motion carries. Next item.
Next item is AB 1306 Burke. This bill will remove the physician's supervision requirement for certified nurse midwives, allowing CNMs to manage a full range of primary health services, perform peripartum care, provide emergency care when a physician is not present, and perform and repair episiotomies in all practice settings. This bill would require a CNM to provide evidence of current advanced level national certification by a certifying body that meets standards established and approved by the Board of Registered Nursing. This bill would require the BRN, the Board of Registered Nursing, to create and appoint a Nurse Midwifery Advisory Council, which would be similar to the Medical Board's Midwifery Advisory Council. This bill would authorize a CNM to manage a full range of primary health services for women from adolescence beyond menopause, including primary health care, gynecologic and family planning care, preconception care, care during pregnancy, childbirth and postpartum period, immediate care of the newborn. This bill would authorize a CNM to practice in all settings and would authorize a CNM to provide peripartum care in an out-of-hospital setting to low-risk women with uncomplicated singleton-term pregnancies who are expected to have an uncomplicated birth. I can go through the exact, it's in your analysis, but that's kind of the summary if you don't want me to go through each thing.
That's fine.
Okay, because there's going to be a lot of these scope bills that kind of lists each thing, and instead of doing that, I was planning on doing a summary unless someone actually wants me to go through each service.
I think we should start with the summary.
Okay.
That's fine. Thank you.
Okay, so this bill is AB 1308 in 2013 also removed physician supervision for licensed midwives, but it was, the board supported that bill at that time because it was very restricted and clear on what types of patients licensed midwives could accept and required physician consultation and approval for patients that did not meet those requirements. This bill would allow CNM to accept all patients as long as they are low-risk women with uncomplicated singleton-term pregnancies who are expected to have an uncomplicated birth. This bill does not define low risk or uncomplicated birth, and so that would be left to the judgment of the CNM. This bill would provide that the practice of nurse midwifery emphasizes informed consent, preventative care, and early detection and referral of complication to a physician. However, this bill does not define informed consent or when a CNM has to refer a patient to a physician and for what types of complications. This bill would require CNMs working in a hospital setting to collaboratively care for women with more complex health needs, but does not define collaborative care or complex health needs. And lastly, this bill does not require the council required by this bill to have a physician member, and this has been an important member in the board's experience with the Midwifery Advisory Council. In addition, it's also unknown how this bill would affect corporate practice, as the bill does not address this issue. So taking all these things into account, board staff is recommending the board oppose this bill unless it's amended to address the concerns indicated.
Thank you. What is the pleasure of the board?
So let me ask you a question. With the oppose unless amended, means that you don't work with the author anymore to try and get anything done? I mean, is it better to go for a neutral position unless amendment?
No, so oppose unless amended actually does, it basically sends out the message, although we have strong concerns with this bill, but we want to work with you to try to address those concerns. A straight oppose would be, we hate this bill no matter what, and there's nothing we can do.
But I'm looking between neutral unless amended
it just
versus
depends,
oppose versus amended.
It depends on how strong the board's members' concerns are, because neutral is, it's kind of, it's a less strong position to take. So it's like, we have concerns, but they're not as strong as an opposed unless amended. So it really depends on how strongly the board's concerns lie in this area. And I kind of based my position, a recommendation on other past scope expansion bills where we thought maybe something could be worked out, but we had strong concerns with the scope expansion.
So with that clarification, I would move to oppose unless amended.
Is there a second? Second, Dr. Bishop, thank you. Discussion or comments from the board members? Seeing none, are there any comments from the public? Yes, ma'am.
Carrie Sparrowan, I'm a licensed midwife. I also chair the Midwifery Advisory Council for this board. I think that one of the things that needs to be addressed in this bill is the fact that nurse midwives are not trained in home birth. And they don't have to have ever attended a home birth to graduate from nurse midwifery school. And that is something that needs to be addressed if we're going to allow them to work without physician supervision in an out-of-hospital setting that they're not necessarily trained in. And a birth is a birth is a birth, yeah, but in home birth, it's a different skill set. There's no anesthesia to call, there's no respiratory therapy to call, there's no blood bank, and you really need to be prepared to handle those emergencies. So I would really strongly suggest that as you work with the author to amend this bill, that those concerns are addressed, that they have to show some evidence of training specific to home birth. Thank you.
Thank you. Is there any additional public comment? Any comment from the phone?
None at this time.
Thank you.
All right. Ms. Toof, can you please call the roll?
Dr. Bolat? Aye. Dr. Bishop? Aye. Dr. Gonadev?
Aye.
Dr. Hawkins?
Aye.
Dr. Kraus?
Aye.
Dr. Levine?
Aye.
Dr. Lewis?
Aye.
Dr. Yip?
Aye.
Ms. Pines? Aye. Ms. Shipsky?
Abstain.
Ms. Wright?
Aye.
Ms. Juroslavsky?
Aye.
Mr. Serrano Sewell?
Aye, the motion carries.
Okay, ACR 29. This resolution would make findings and declarations regarding the importance of organ donation. It would proclaim April 20th, 2015 as DMV Donate Life California Day and the month of April 2015 as DMV Donate Life California Month, and would encourage all Californians to register with the Donate Life California Registry. The board staff suggests the board support this bill, this resolution.
Is there a motion to accept?
So moved.
Support? So moved. Seconded. Thank you. I see no discussion. Are there any comments from the public? Seeing none, are there any comments from the phone?
Comments on the line?
None at this time.
Thank you.
Thank you. Please call the roll.
Dr. Bolat? Aye. Dr. Bishop? Aye. Dr. Gonadev?
Aye.
Dr. Hawkins?
Aye.
Dr. Kraus?
Aye.
Dr. Levine?
Aye.
Dr. Lewis?
Aye.
Dr. Yip?
Aye.
Ms. Pines?
Aye.
Ms. Shipsky?
Aye.
Ms. Wright?
Aye.
Ms. Juroslavsky?
Aye.
Mr. Serrano Sewell?
Aye. Motion carries. Next item.
Next item, SB 22 Roth. This bill we actually the board took a support and concept position at the last meeting, but it has been substantially amended since then. It would now require the Office of Statewide Health Planning and Development, or OSHPD, to establish a nonprofit public benefit corporation, which would be called the California Medical Residency Training Foundation, or Foundation. The foundation is required to be governed by a board of trustees consisting of a total of 13 members. 7 members would be appointed by the governor, 1 would be appointed by the Speaker of the Assembly, 1 by the Senate Committee on Rules, and 2 members would be members of the Medical Board of California, appointed by the Medical Board of California, and 2 members would be members appointed by the Osteopathic Medical Board of California. The foundation would solicit and accept funds from business, industry, foundations, and other private or public sources for the purpose of establishing and funding new residency positions in medically underserved areas of California. The foundation would also make recommendations to the director of OSHPD on the establishment of new residency positions and prepare and submit an annual report to the legislature. This bill would require OSHPD to provide technical expertise and staff support to the foundation in meeting its responsibilities and financial management for the foundation. This bill would also require OSHPD to establish criteria for ranking the geographical areas in California that have the highest need for primary care residencies and give preference to proposals that would establish residency positions in these areas. OSHPD would be required to solicit proposals for new residency positions from public and private sector institutions, enter into contracts with public and private sector institutions, and the director of OSHPD would seek recommendations of the foundation as to which proposals best fulfill the objective of this bill. This bill would set forth a framework that would allow OSHPD to establish a nonprofit, establish a foundation which would solicit new residency positions, and the foundation would be governed by the Board of Trustees, which would include 2 members appointed by the board. This bill would increase funding for residency positions in California, which will help to promote the board's mission of increasing access to care for consumers. As such, the board staff is suggesting the board support this bill and change our position from support in concept to support.
So I'll move to support this
Thank you. Is there a second?
motion.
Second.
What else want to speak?
Ms. Yaroslavsky? There's been a motion and a second. You can speak to it if you wish. And then,
I just want to make sure, as far as clarification, that members here realize that I sit on the Health Profession Educational Foundation Board as your representative, and we do administer the Stephen Thompson Loan Repayment Program, of which Senator Roth was not aware of the program, nor what we do as far as that goes. I think it's an interesting idea to be able to solicit money from sources, and hopefully it will be done in a blind fashion so that people won't figure that they're buying any kind of a opportunity. But Senator Roth was extremely pleased to hear about the work that the medical board has done previously as far as sponsoring and loan repayment programs, and the work that everyone here has been doing. But I hope it works out, that this does in fact work out, but there's no guarantees in life. So,
Dr. Levine?
Thank you, and I totally support the notion of expanding graduate medical education residency positions. I guess my concern is, and it's not a concern that would change my vote on the bill, is that it is very disruptive to have an unstable and unpredictable source of funding for residency programs. These are multi-year commitments. It takes 4 or 5 years to stand up a residency program, to get through the residency review committee process, and to do that, without the sense that you can continue on. It is very hard for residents who are halfway through their training program, learn that the 3rd year is not going to be available, or who are trying to get a job from a residency program that no longer exists. So I hope that as the funding source is considered, I think we need to be somewhat cautious about ensuring that when a program is stood up, that there is a confidence that it will be able to endure and continue.
The support for anything to increase the residency programs in California is great. This is unfortunately a complicated way of doing it rather than straightforward way. Many states do provide state funding, but this is just to go around. As many of you are aware that I was a member of the 1115 waiver task force for the Medi-Cal managed care for the next 5 years, and we're trying to get some money on the workforce development for the residency program. So there are multiple ways. Senator Roth has a good heart. I think it's just a little complicated way, but anything like Dr. Levine mentioned, we got to make sure that it's stable funded. It's anywhere minimum 3 years, and it can go up from there, and you got to have funding for that. So as long as it does, whatever increases the number of slots in California, which is probably the worst when it comes to most populated states, because we were the younger state, and all the residencies were in the East Coast, so that's why we don't have funding. So if anything which improves, we should be there.
Thank you. Are there additional comments from the board? No. Any comments from the public? Any comments from the phone?
Not at this time.
Thank you. Ms. Tuve, please call the roll.
Dr. Bolat? Aye. Dr. Bishop?
Aye.
Dr. Gonadev?
Aye.
Dr. Hawkins?
Aye.
Dr. Kraus?
Aye.
Dr. Levine?
Aye.
Dr. Lewis? Aye. Dr. Yip?
Aye.
Ms. Pines?
Aye.
Ms. Shipsky?
Aye.
Ms. Wright?
Aye.
Ms. Yaroslavsky?
Aye.
David Serrano Sewell.
Motion carries.
All right. Next bill.
9 more. We're getting there. Good job.
Okay. SB 277 PAN. This bill is in your update package. This is the bill that would eliminate the personal belief exemption from the requirement that children receive specified vaccines for certain infectious diseases prior to being admitted to any private or public elementary or secondary school, child care center, day nursery, nursery school, family daycare home, or development center. This bill would specify that if CDPH or California Department of Public Health adds an immunization to the list in the future, that personal belief exemptions would be allowed for that additional immunization. This bill would exempt a pupil in a home-based private school or a pupil who is enrolled in an independent study program from the immunization requirements. This bill would expand existing annual notification requirements for school districts to include notifications to parents or guardians of the immunization rates for each of the required immunization for the school in which a student is enrolled. Vaccines have been scientifically proven to be effective in preventing illnesses. Ensuring that children receive the ACIP recommended vaccination schedule is the standard of care unless there is a medical reason that the child should not receive this vaccine. But the bill would still allow for a medical exemption to address these circumstances. As such, board staff is suggesting that the board support this bill.
I would move to support this in a motion.
There's been a motion and a second. Is there any discussion or comments from the board? Seeing none, I have one speaker card, Ms. Yvonne Chung.
Yvonne Chung with the California Medical Association. CMA is a co-sponsor of this legislation. The medical community is united with thousands of concerned parents and families behind the need to increase vaccination rates. The goal of SB 277 is to protect children and our communities from disease and death resulting from vaccine-preventable illnesses. The recent measles outbreak shows how quickly a disease can have widespread impact, and a person's refusal to vaccinate their children puts their child at risk of catching and spreading vaccine-preventable diseases and puts people who can't vaccinate at risk. The choice doesn't just impact that family, it reverberates across the community, and that's why we are joined in support by groups across the state, including local government, children's groups, and groups from the education community in support. And we really appreciate the medical board support as well. Thank you.
Dr. Yost?
I started life as a pediatrician, and just as a former public servant as well. I'm now just a member of the public like the rest of you, but I just wanted to voice my very strong support for SB 277 and would thank you if you would support it as well.
Thank you very much. Is there any additional public comment? Seeing none, are there any comments from the phone?
Do we have any comments on the line?
All right.
Hello?
Hello? Hi, I'm just a concerned parent, and I'm just hoping that you guys can take another look and allow parents to make this decision for themselves. It's not up to medical providers, the government, anybody. You should allow parents to make their own decision. If vaccines work so well, then the people out in the public can be out in the public with unvaccinated people. It shouldn't be a problem. They do it now. And measles is not, it's highly contagious, but it's not killing anybody. And I think that's what you should really look at and allow parents to make their own decision because we have to take care of our children ourselves. Thank you.
Thank you for your comment. Are there additional comments from the phone?
Not at this time.
Thank you very much. Ms. Tuve, please call the roll.
Dr. Bolat? Aye. Dr. Bishop? Dr. Gonadev?
Aye.
Dr. Hawkins?
Aye.
Dr. Kraus?
Aye.
Dr. Levine?
Aye.
Dr. Lewis? Dr. Yip?
Aye.
Ms. Pines?
Abstain.
Ms. Shipsky?
Aye.
Ms. Wright?
Abstain.
Ms. Yaroslavsky?
Aye.
Mr. Serrano Sewell?
Pardon me. Aye. The motion carries. Next item.
Next item is SB 323 Hernandez. You may have remembered the scope expansion bill for nurse practitioner from a couple years ago. This bill is very similar to that bill. There are a few differences. Is the bill does limit the practice settings where a certified NP can practice. So this basically would authorize a nurse practitioner who holds a national certification from a national certifying body recognized by the Board of Registered Nursing or a certified NP to practice without the supervision of a physician if the NP practices in a clinic, a specified health facility, a group practice, a medical group, or an independent practice association. This bill would allow a certified NP practicing in any of these settings to perform specific patient care functions without physician supervision. This bill would require a certified NP to refer a patient to a physician or other licensed healthcare provider if a situation or condition of the patient is beyond the scope of the education and training of the NP. This bill would require a certified NP to maintain professional liability insurance appropriate for the practice setting. This bill significantly expands the scope of practice of a certified NP by establishing independent practice for those certified NPs that work in specified settings. NPs are well qualified to provide medical care when practicing under standardized procedures and physician supervision. But the standardized procedures and physician supervision, collaboration, and consultation are an existing law to ensure that patient care provided includes physician involvement and oversight. In the latest policy committee hearing, the opposition did bring up potential oversight of certified NPs by the Medical Board of California, but it's unclear how the board could have regulatory authority over a licensee of another board or the BRN. So I just told the committee staff, the committee, that I would bring this up in the analysis, but it wasn't very clear how that would happen. Taking all these into account in the board's position of oppose, last time this bill was in the legislature a couple years ago, board staff has recommended the board again take an opposed position on this bill.
There's been a motion and a second by Dr. Bishop to oppose unless amended. To oppose, apologies, to oppose. All right, so noted. Are there any additional comments from the board? Dr. Levine. My glasses are.
Just one other additional comment or concern is that the issue of the bar and the corporate practice of medicine. Since what this bill would do would be essentially say certified nurse practitioners are practicing medicine. So there's fuzziness about regulation, but there's also fuzziness about the application of the bar and the corporate practice of medicine as the likely employers of many of these NPs might be minute clinics, for example, where the employer is not a professional. The employer is actually a corporate entity. So there are a number of issues in addition to the scope issue that I think complicate this bill.
Thank you. Seeing no further comments, I'll see if there's comments from the public. I don't have a speaker card. Any comments from the phone?
None at this time.
Thank you. Ms. Toop, please call the roll.
Dr. Bolat? Aye. Dr. Bishop? Aye. Dr. Gonadev?
Aye.
Dr. Hawkins?
Aye.
Dr. Kraus?
Aye.
Dr. Levine?
Aye.
Dr. Lewis?
Aye.
Dr. Yip?
Aye.
Ms. Pines?
Aye.
Ms. Shipsky?
Opposed?
Ms. Wright?
Aye.
Ms. Yaroslavsky?
Aye.
Mr. Serrano Sewell?
Aye. Motion carries.
Okay, next bill, SB 337 Pavley. This bill would establish an alternative means for a supervising physician to ensure adequate supervision of a physician assistant or PA for routine care in the administration, provision, or issuance of a Schedule II drug. This bill would add 2 additional mechanisms in addition to the existing 5% medical record countersign requirement for supervising physician to choose from to ensure adequate PA supervision. The 2 additional mechanisms are, the first one is the supervising physician and the PA shall conduct and document a medical records review meeting at least 10 times annually, which may occur in person or by electronic communication. And the second mechanism added is the supervising physician shall supervise the care provided by the PA through a review of those cases or patients deemed appropriate by the supervising physician. The review methods used shall be identified in the delegation of services agreement, and it may occur in person or by electronic communication. Existing law requires all medical charts for Schedule II drug orders to be countersigned within 7 days by the supervising physician. This bill would create an additional mechanism for a supervising physician to ensure adequate supervision of the administration, provision, or issuance by a PA of a Schedule II drug order. The additional mechanism is only allowed if the PA has documentation evidencing the successful completion of an education course that covers controlled substances and meets specified standards. The mechanism would only require the supervising physician to review, countersign, and date within 7 days a sample consisting of the medical records of at least 20% of the patients cared for by the PA for whom the PA Schedule II drug order has been issued or carried out. I would like to point out that board staff did receive a support letter from the California Association of Physician Groups. It's not mentioned because it wasn't in the committee analysis, but I just want to point this out, and they support the bill. While the intent of this bill is to provide flexibility and allow for a more team-based approach in PA supervision, the option that allows a physician to review cases as a physician deems appropriate may be too broad and may not ensure adequate supervision of PAs. There needs to be a base included in this language related to the required physician review, similar to the medical records review meeting requirement. With the language currently in the bill, a physician could decide that a review of 2 cases a year would be appropriate and comply with the statute. However, this would not ensure adequate supervision. In addition, this bill would significantly reduce the physician review of medical records for Schedule II drug orders from 100% to 20%, although additional education would be required. Although this bill would require the reduction in physician review is substantial. So for these reasons, board staff is suggesting the board oppose this bill unless it is amended to address concerns.
Thank you. Ms. Yaroslavsky?
I was going to make the motion.
Please.
Fine. Make the motion as heard, stated.
All right. Motion and a second. Are there additional comments from the board? Dr. Bishop?
As physician, as medical board representative on the PA board, I was there for this discussion on Monday about this bill. And the board, as I recall, voted to, again, oppose unless amended. Part of the problem with this effort at that board meeting was that because of procedural difficulties, the board was not able to really ask staff to express any of the concerns to the authors of the bill. And I was hoping that today, as we proceed with our discussion, that we would be able to express those concerns that we have, such that I believe the intent of the bill is sound, but I believe there are serious problems with it. And I was hoping we, as a medical board, could hopefully help our staff to provide some guidance to the authors as it moves forward. I would like to see perhaps this salvaged in some way. I think there are some positive things for it.
Thank you for sharing the discussions this week. Yes, Doctor.
I support the stand what we're taking. I think one of the issues I had is with especially with the prescription drug problems. How are we going to even weaken whatever supervision we have right now? That it just doesn't make sense to me. So we got to be very careful when we look at the issues with the prescription drug abuse, which we already went through at length on another bill. So let's make sure that we work with the author, make sure all those consumer protections are there before we take a stand other than oppose.
All right. I do have speaker cards.
And before we go to the speakers, just
Sure.
to be clear, I need to know if the board actually has a concern with moving the Schedule II review from 100 to 20. I mentioned that as a concern, but I just need to, if we do take an oppose unless amended position, kind of need to know if the board feels the same way, if they have a concern with that.
Kimberly, would you want to opine on that piece of it?
Yeah, I was with Jennifer when we discussed it, and we both have concerns from going 100% to 20%. We don't think that is true consumer protection to go that far down.
So that is your recommendation?
Our recommendation is to
Is that
change it.
incorporated in your motion, Ms. Yaroslavsky?
Absolutely, and yes, and I have a question as well.
Okay.
A clarification question. As we're seeing these bills come forward, which is more of a collaborative care model, patient-centered, doctor-centered situation, it's crossing the waters of a whole lot of different areas. Is there maybe the idea that we should be taking a look at, in the general perspective of the practice of medicine and how we support this collaborative, integrative approach, that maybe we should come up with some kind of a overview or a compendium of something that we will go forward with when these different authors are coming up with for each and every single different facet of the practice of healthcare?
Part of our compendium does include scope of practice. It's just hard because each bill kind of proposes a different thing. And so I know kind of generally where the board lies on scope of practice and that we want involvement of a physician in most cases, but, you know, and we provide that kind of input, but it's hard to take a general because each of them kind of like, for example, the nurse practitioner bill changed from the settings. So, you know, the optometrist bill changed a little bit. We'll go over that in a little bit, but that changed enough for kind of, we can't just take a blanket position, but.
No, I understand, but with legislators, maybe if they understood where we were coming from and it crosses the barriers and the boundaries to having this happen, that if they understood up front, maybe they could put their words together better is all.
So just to let you know, most of these bills have, the PA one is new, but most of the other bills that we have seen coming back, and we continue to provide our 2 cents comments on it, but you can see that they haven't really changed with the exception of the optometrist bill. So we can always go and we go and we tell them our concerns and how we think it should change to pass for us to support it. But at the end of the day, the next year they come up with sometimes the same bill. But we are trying to bring our voice forward.
Dr. Kraus?
It almost seems as if everyone wants to practice medicine except doctors.
Speak for yourself.
I hope that next year we don't face a bill for the barbers asking return for their privileges for surgery. But in any event, I think that Ms. Yaroslavsky's comment is of great concern, and I know that we're just one part of the Department of Consumer Affairs, but whether it be in collaboration with every other healthcare board or something that we would endeavor to do on our own, we do have to find a way of providing equal protection for the public, whether a surgical procedure is done by a nurse or a MD, we would want that surgical procedure to be done at the same standard of care, the same expectations of outcome. So I don't know that it needs to be addressed in reference to this bill, but perhaps the chair would consider convening a task force or a committee to talk about these overarching concerns.
All right. Are there additional comments? Dr. Yep.
And we all try to create an environment that we shortage, and then we kind of tend to loosen up supervision. I mean, we need doctors, we need PA, we need NP, no doubt, but we'll be careful. As a practicing physician, I can see some of my patients come to me, they don't even know who their primary care is. And they have never seen the primary care. They think the PA is the doctor. So that tells you how much supervision is there. I think we need to be careful when we try to move along, getting extra help for the care of the Californian. And also, you know, in the hospital system, we have a problem even kind of supervising, the first supervising physician to do the job, to like countersign order within 24 hours, do HMP within 24 hours, supervising the PA. If we start losing control, I think we're going to look at disasters.
Thank you. The first speaker's card I have is Dr. Richard Granesi. Sorry, I apologize. Please. And then Teresa Anderson, Greg Meany, and Jeremy Adler. Sir.
Good afternoon. Did I press it? Oh, good afternoon. My name is Dr. Richard Granese. I want to first say before I start, when I was talking about coming to testify before the Board of Medicine, I was petrified because I hope to never be in the situation where I have to become before the Board of Medicine again. But I do have tremendous respect for what you're doing, and I do want to thank you sincerely. This is a difficult process and a difficult chore that you guys are tasked with, and now at least I know a little bit more about what the board does. I am a psychiatrist, and I have been in practice in Orange County for about 10 years, and I'm in private practice. Prior to moving to Orange County, California about 10 years ago, I was the Associate Training Director at West Virginia University School of Medicine, where I taught medical students and residents. The reason I mention that is just to illustrate that I'm no stranger to what supervision is all about. I still continue to teach medical students, PA students, and some physicians at times. So the Affordable Care Act has changed the landscape of medicine and how we're going to be practicing, and obviously we have millions of people now coming into the healthcare system trying to access care. The problem is with this enormous influx, we don't have enough providers. Physician assistants are an extension of the physician that they work with. They're integral to the medical team, and they're essential in expanding access and increasing care. In the years I've been practicing medicine, I've had physician assistants and nurse practitioners, and I'm very familiar with supervision for both. Supervision should be meaningful. The ultimate responsibility does fall on the physician, and the physician should have the ability to tailor the method of supervision. Supervision should focus on innovation, and I really don't think the one-size-fits-all model is legitimate and should be continuing in the future. Supervision is not the same as a co-signature. Co-signing electronic medical records a formality. Case review is better. I've heard some suggestions about doing medical case reviews with the physician assistant. I think this is a great way to do some supervision and actually do some training. I believe this Senate Bill 337 is not to reduce supervision by any stretch of the imagination, but to make it more real, to not increase the burden of more paperwork, but to make it real supervision. It also doesn't take into account the experience and the training of the physician assistant. I've had physician assistants who have had 10 years of experience in the field, and I've had others that I've brought right out of training that I've taught. And so signing the same number of charts I don't think makes sense. Talking about the controlled medications, I think that the burden of signing 100% is not necessary. The suggestion is 20% after the physician assistant has attended a course. A lot of times the prescriptions have already been filled at the pharmacy before the physician will even see the record. Think about it, they're gonna get the prescription, go straight to the pharmacy. I think the main goal of utilizing the PAs is to increase access to care in those underserved areas. So I just want to thank you for your time and consideration.
Thank you, Doctor, for your comments. The next speaker card I have is Teresa Anderson.
Thank you. Teresa Anderson on California Academy of Physician Assistants. We are the sponsors of this bill. And I just want to say thank you. Kim and Jennifer have been wonderful. We have talked to them and worked. We do understand that there's some thresholds that need to be looked at and some of the, tighten up some of the language around the deemed appropriate piece of the bill. A couple of things that I heard that I just want to address real quick. This bill in no way reduces supervision. The physician is still 100% responsible for the care provided by the PA. So when we're talking about really looking at this bill, it's about the documentation piece of how are you documenting supervision. So just want to clarify that piece of it. And in terms of a response for Dr. Yip's question or comment related to primary care providers and patients not knowing who their primary care provider is, that they think it's the PA. Quite often the PA is a primary care provider in team-based care. So, you know, looking at sort of expanding that team-based model and really, you know, accommodating the people that were the patients that are coming into practices is a really big part of this. So in looking at some, I know you guys all have some a beautiful packet of reading material in front of you, and we added to that substantially. So you know, have nothing else to do on your way home. But anyway, in that packet, the course that we talk about related to the controlled substances is all very, very, very detailed, and every slide that is part of that is in that packet for your viewing pleasure. And that really describes the 20%. There's a background piece in there about the 20% and how we came up with that. But again, I just want to say that we're really happy to keep working and move forward and talk about some of the things that could tighten this bill up and make it something that you all could support. So thank you very much for your time.
Thank you for your comments. Greg?
I was going to say good morning, but I think it's afternoon now, right?
Good afternoon.
Good afternoon. So my name's Greg Manning. I'm a practicing physician assistant, and I want to thank you for letting me speak to the bill. Chart co-signature remains the law of the land, even as charts as the law was designed for no longer exist for us. As time and technology advances, it makes sense to examine some of these outdated areas in their regulations and laws. They seemed probably appropriate back then, you know, decades ago, but maybe less so now. So I've been in family practice for about 21 years. I work as a faculty member in a family medicine residency physician training program. And the residents now that come in, they kind of look like my kids. You know, I'm getting a bit older and they're getting a bit younger. So medicine's changed, medical training has changed, the scope of the providers and their responsibilities have changed, and my practice and skills have advanced over the years, and my relationship with my supervising physicians and I have also changed over that last 21 years. Practicing in partnership this long, I can tell you that it does make sense to increase options for documentation and supervision that reflects the advances in team-based care. And this is really meant to encourage more meaningful and practice-specific documentation and supervision. We have an overburdened system. We want to unburden that system a little bit, but in no means take away the notion of our dependency as a practitioner with our physicians. Teaching in a residency program, we use a variety of processes to supervise interns, new doctors, and residents in their patient care duties. We have chart audits and large group weekly reports, lunchtime case discussions. I sometimes insert myself into those to get my own feedback and to use that as my supervision as well. And it seems to be a lot of variety of ways to actually have more meaningful supervision than a signature on an electronic record now or a chart. SB 337 only offers a very small change to our current law by updating and recognizing there are other ways to document supervision and ensure adequate, safe, team-based healthcare. It doesn't change any supervision requirement of my doctor. I'm not in the practice of medicine. I'm in the extension of medicine of my physician. So this just allows me, as a team member of the physician and physician assistant team, to design a process that works best for our practice, as opposed to this sort of one-size-fits-all legal requirement. So healthcare is growing, patient needs are growing, practices across the state are trying to accommodate all this increased load with the Affordable Health Care Act, allowing those of us in the trenches to design our own processes of supervision and create, I think, much more meaningful ways than a signature on a chart at the end of the day or a few days later is really the best approach. And I hope that you can get behind SB 337 for us. Thank you.
Jeremy Adler.
Good afternoon. Good afternoon, and thank you for the opportunity to provide public comment about SB 337. My name is Jeremy Adler. I've been practicing as a PA in pain management for 15 years. I have a master's degree specializing in pain management. I'm also co-author on national guidelines, which were prominently referenced in the medical board guidelines on opioid use for pain. I'm on the San Diego Prescription Drug Abuse Task Force, and I advised on Cures updates. I'm also the current president of the California Academy of PAs. As both a practicing PA and consumer of healthcare, I believe that healthcare must not only be accessible, but of high quality and safe. I recognize and applaud the service of our regulatory boards providing Californians safe access to healthcare. The PA profession was developed by physicians for physicians to expand access to care, which is both high quality and safe, fundamentally placing responsibility on the physician to supervise the PA. Adequate supervision ensures the care received by the patient is no less than would have been provided by the supervising physician. Decades have proven that this physician-led team-based model works, and nothing in SB 337 changes anything related to the supervision requirement. Physician supervision is not a co-signature. A co-signature happens after care is delivered. Supervision is rather the interactive relationship between PAs and physicians that ensures the patient receives appropriate care. Physician supervision has long been the practice in other physician-supervised health professions, for example, nurse practitioners, without any required co-signature or chart review, including Schedule II medication. SB 337 recognizes that it is the physician who accepts responsibility for the patient and PA, and therefore, rather than a one-size-fits-all model, offers the physician flexibility in the methods they choose to document their supervision mandate, balanced with sufficient safeguards to ensure that the consumer is protected. As a PA practicing in pain management, I am all too aware of the safety concerns related to abuse and diversion of opioids. The rescheduling of hydrocodone combination products was multifactorial, but a significant component focused on thwarting criminal activity, such as fraudulent phone-in prescriptions. The impact on supervising physicians and PAs has been significant as a result. Our intent in SB 337 is to provide the right patient, the right medication, at the right time. First, California's specific Schedule II training would be required for PAs eligible for anything other than 100% co-signature. This includes medical board guidelines and full utilization of cures. And the syllabus, as Teresa mentioned, is in the handout there. Second, even with additional training, It is at the sole determination of an unrestricted licensed physician and surgeon to modify the number of charts signed, with statute defining a minimum. And finally, data suggests that with the rescheduling of hydrocodone, even with the minimum proposed, more actual charts containing Schedule 2s would be reviewed and co-signed than prior to rescheduling. In summary, SB 337 will enable flexibility in how physicians document the requirement of PA supervision without changing the mandate to supervise. This flexibility encourages and enhances team-based care to ensure patients have safe access to high-quality care. Thank you for your time.
Thank you, Mr. Adler, for your comments. I have no other additional speaker cards from the public. Are there any comments from the phone?
Not at this time. Thank you.
All right. Pardon me. Ms. Toof, can you please call the roll?
Dr. Bolat? Aye. Dr. Bishop? Aye. Dr. Gonadev?
Aye.
Dr. Hawkins?
Aye.
Dr. Kraus?
Aye.
Dr. Levine?
Aye.
Dr. Lewis? Dr. Yip?
Aye.
Ms. Pines?
Aye.
Ms. Shipsky?
Aye.
Ms. Wright?
Aye.
Ms. Yaroslavsky?
Aye.
Mr. Serrano Sewell?
Aye. Motion carries. Thank you, members. Next item.
Okay, SB 538 block would expand the scope of practice for a naturopathic doctor and would allow an ND or naturopathic doctor to prescribe certain drugs without physician supervision and perform minor procedures, including allowing an ND to perform operative procedures relative to superficial lacerations, superficial clinically benign lesions less than 1 centimeter not located on the face, and superficial abrasions. I can go through all of them, but that's just kind of a summary. The bill expands the scope of practice of an ND and would allow an ND to prescribe specified drugs without physician supervision and perform minor procedures. Although NDs may be well qualified to practice naturopathic medicine that utilizes natural medicine and treatments in a natural approach, NDs do not receive the education and training in naturopathic education programs to safely perform minor procedures and prescribe without physician supervision. Physician supervision helps to ensure that patient care being provided by an ND includes physician involvement and oversight. The board's primary mission is consumer protection, and the board staff is suggesting that the board take an opposed position on this bill.
Thank you. Is there a motion?
So move.
Moved and seconded. Are there comments or questions from the board on this bill? Dr. Lewis made the motion and Dr. Levine made the second. Is there any comments on SB 538 from the members? Seeing none, are there comments from the public? No comments? Any comments from the phone?
Any comments on
Not
the
at
phone?
this time.
Thanks.
Thank you. Ms. Toof, please call the roll.
Dr. Bolat?
Aye.
Dr. Bishop?
Aye.
Dr. Gonadev?
Aye.
Dr. Hawkins?
Aye.
Dr. Kraus?
Aye.
Dr. Levine?
Aye.
Dr. Lewis? Dr. Yip?
Aye.
Ms. Pines?
Aye.
Ms. Shipsky?
Aye.
Ms. Wright?
Aye.
Ms. Yaroslavsky?
Aye.
Mr. Serrano Sewell?
Aye. Motion carries. Thank you. Next item.
Next bill, SB 622 Hernandez. This, again, we're seeing the optometrist scope expansion bill back. So this bill would expand the scope of optometrists to include the ability to order specified tests, perform laser and minor procedures, and administer specified vaccines. Following lengthy negotiations with stakeholders, the author proposed amendments to address concerns raised. This bill would now allow the California Board of Optometry to establish educational and examination requirements by regulation for licensure. And this bill would also require the California Board of Optometry to develop regulations authorizing optometrists to use non-invasive, non-surgical technology to treat a condition authorized by law. So instead of going through everything an optometrist is allowed to do, basically the three main categories are what I said: order specified tests, perform laser and minor procedures, and administer specified vaccines. If you have questions on the specific what they're allowed to do, I can answer those. They're also in the analysis. This bill would specify optometrists diagnosing or treating eye disease shall be held to the same standard of care to which physician and surgeons and osteopathic physician and surgeons are held. This bill would require an optometrist to consult with, and if necessary, refer a patient to that physician and surgeon or other appropriate healthcare provider when a situation or condition occurs that is beyond the optometrist's scope of practice. Lastly, this bill would state legislative intent that the Office of Statewide Health Planning and Development, under the Health Workforce Pilot Projects Program, designate a pilot project to test, demonstrate, and evaluate expanded roles for optometrists in performance of management and treatment of diabetes, hypertension, and hypercholesterolemia. So this bill really has been amended and narrowed compared to the bill from last year, but it still does allow expanded scope of practice for optometrists. Some of the hours of training and the number of procedures required were upped in this bill, but it's still unclear if they're enough to actually allow optometrists to perform these procedures. I mean, it's taken some steps in the right direction, but there's still the question is there enough training and education to ensure consumer protection and allow optometrists to perform these kind of procedures? Going along with our position last year, we took an oppose unless amended. Board staff is again suggesting an oppose unless amended position, and the amendments would really be to require more education and training and more procedures. So that's the position that staff's recommending.
Is there a motion?
So move with one addition.
Yes.
And that would be to also request an amendment that for some transitional period, there would also be medical board oversight.
Why don't we take what's before us, Dr. Kraus, if you don't mind? I'd ask you to withdraw the second part.
That's fine.
Thank you. Is your motion okay? Then we'll take the motion as oppose unless amended. There's been a motion and a second. Are there comments from the board?
So
Yes, Dr. Hawkins.
question. Does anyone know the motivation for vaccinations?
I just think it's always kind of been part of the scope expansion. Maybe Dr. Kraus knows a little bit more.
One of the issues has always been that the scope of practice of optometry does not include the administration of injections. And the principal interest in injections would be, number one, for intravenous fluorescein angiography for the study of retinal diseases, and number two, for injection of a variety of pharmaceutical agents into the eye for the treatment of macular degeneration and diabetic retinopathy. So the request for vaccination appears to be a gateway, so to speak, to the use of the needle. It's particularly ironic in that the author of the bill abstained in committee on the vaccine bill.
Thank you for those observations, Dr. Lewis.
Excuse me, Jennifer, excuse me. In your discussions with the author regarding the expanded scope of practice regarding treating of diabetes, hypercholesterolemia, hypertension, what was your feeling with why he wants to go into that direction? My reason is that I'm a little uncomfortable with the optometrists treating those kind of conditions, which have really been under the scope of the physician, the PA, the nurse practitioner, that group of more learned people.
So this bill doesn't actually include that. It just basically encourages OSHPD to do a HWPP study, which we've kind of seen in the past. So it doesn't really encourages, but it doesn't include that in the scope for an optometrist in this bill, but you can kind of see they're going the pathway of wanting to do an OSHPD study. But that is one way they narrowed it. So they took it out of the bill, but they encouraged that study instead. And to be honest, we haven't had a lot of discussions with the author on this one because the stakeholder group has not included the medical board. And so although they know where we stand because they've received our letters, we haven't been involved in that stakeholder setting. It was a really limited stakeholder group, and we weren't invited. So that's just kind of how this went. But they are aware of our position because they were sent position letters. So.
Thank you. Dr. Levine?
I believe part of the rationale is that an optometric exam of the eye can show evidence of hypertension, diabetes, and hyperlipidemia. And so the ability to then just treat it rather than saying you have high blood pressure, I can already see the effects in the eye, you need to see a doctor, a physician. And I think that's the rationale for the selection of those three conditions.
Dr. Kraus?
The standard of care in general ophthalmology is to diagnose and refer. If it's an emergency, to the emergency room, otherwise to a internist or family physician. It's not the custom for ophthalmologists who are medical doctors to be the primary care providers for the treatment of hypertension and diabetes and so on.
Thank you. Yes.
Just an interesting comment. In the background, I saw that per the committee analysis, an optometrist is an independent primary healthcare professional for the eye. That itself bothered me. That the primary care doc, I have a lot of respect what they do, and you shouldn't be calling primary care doctor for a toe or an eye or a foot or something. It just bothers them.
Thank you for those comments. Why don't we see if there's public comment? Is there any public comment? Seeing none, is there any comment from the phone?
Not at this time.
All right.
Just a quick question. Say opposed, again, is this one of those positions, if we say just oppose, then we can't get our foot in the door if he should open it up?
I mean, we
Just
could do a
oppose.
straight oppose. Last year we did an oppose unless amend because we thought maybe if maybe education was upped or the number of procedures,
Yes.
maybe it could be more workable. Like the nurse practitioner bill, it's basically independent practice. So there's kind of no in between. It's either you go for independent practice. So that was the reasoning behind suggesting an oppose unless amend. And I know that a lot of the opposition is really working at this and. They're close, except for on the number of procedures and education, but that doesn't necessarily mean they're close. I mean, it's still a big divide between what education people think they should get, how many hours. It's basically the number of hours and the number of clinical procedures that everyone's, really far apart on right now.
All right.
A brief comment to Dr. Lewis's foot in the door, and that is in the last iteration, when this was then in Senator Bonilla's Business and Professions Committee, there was a working group that was convened, which was initially designed to include the optometry board, the medical board, the California Eye Physicians and Surgeons, the CMA. All the stakeholders sat down and actually had extended meetings over many days and weeks about what would be required for these procedures to be safely done. And interestingly, very early on in the process, mysteriously the medical board was no longer invited. So regardless of our position, it's still going to be difficult for us to maintain a dialogue, and I think we're left stuck simply protecting the public.
Thank you. Are there comments from the public, from those present? Seeing none, are there any comments on the phone?
Not at this time.
Thank you. Please call the roll.
Dr. Bolat? Aye. Dr. Bishop? Aye. Dr. Gonadev?
Aye.
Dr. Hawkins?
Aye.
Dr. Kraus?
Aye.
Dr. Levine?
Aye.
Dr. Lewis?
Aye.
Dr. Yip?
Aye.
Ms. Pines?
Aye.
Ms. Shipsky?
Aye.
Ms. Wright?
Aye.
Ms. Yaroslavsky?
Aye.
Mr. Serrano Sewell?
Aye. Motion carries. Next bill.
All right, SB 738 Huff would provide liability protection for physicians writing standing order prescriptions for epinephrine autoinjectors for school districts, county offices of education, and charter schools pursuant to SB 1266 from 2014. According to the author's office, once SB 1266 took effect, many physicians began raising questions about issuing the prescriptions due to liability concerns. Physicians had concerns with issuing standing orders to the school and actually requested this liability coverage in law. So the board has supported bills in the past that provide this type of liability protection for physicians, and so the board staff is suggesting the board support this bill.
Is there a motion to approve from Dr. Lewis, a second? Thank you. Dr. Gonadev. Is there any additional comments from the board? Seeing none, are there any comments from the public? No comments. Are there comments from the phone?
Not at this time.
Thank you.
Ms. Toof, can you please call the roll?
Dr. Bolat? Aye. Dr. Bishop? Aye. Dr. Gonadev?
Aye.
Dr. Hawkins?
Aye.
Dr. Kraus?
Aye.
Dr. Levine?
Aye.
Dr. Lewis? Dr. Yip?
Aye.
Ms. Pines?
Aye.
Ms. Shipsky?
Aye.
Ms. Wright?
Aye.
Ms. Yaroslavsky? Mr. Serrano Sewell?
Aye. Next item.
Last
We're going to
item.
revisit one, so
Okay, SJR 7 pan.
we're almost there. Thank you, Jennifer.
Okay, SJR 7 urges the Congress and the President of the United States to renew funding for the Health Resources and Services Administration's Teaching, Health Center, and Primary Care Residency Expansion graduate medical education programs that are set to expire this year, to lift the freeze on residency positions funded by Medicare, to expand physician supply and improve access to care, and to encourage the development of primary care physician training programs in ambulatory, community, and medically underserved sites through new funding methodologies and incentives. This resolution would encourage increased funding in residency programs in California and would promote more residency positions in California. The board staff is suggesting the board support this resolution.
I make the motion.
Second.
It's been moved and seconded. Thank you. Is there any additional comment from the board? Seeing none. Any comment from the public? Any comment on the telephone?
None at this time.
Thank you.
Ms. Tuve, please call the roll.
Dr. Bolat? Aye. Dr. Bishop? Aye. Dr. Gonadev?
Aye.
Dr. Hawkins?
Aye.
Dr. Kraus?
Aye.
Dr. Levine?
Aye.
Dr. Lewis? Dr. Yip?
Aye.
Ms. Pines?
Aye.
Ms. Shipsky?
Aye.
Ms. Wright?
Aye.
Ms. Jaroslavsky?
The motion carries. Members, there's a request for, oh, yes. Oh, I apologize. Yes, motion carries. There was a request from our Kimberly Kirkmeyer, and we were talking during the proceedings to bring some clarity around the board's SB 482 to ensure that what we discussed and ultimately voted on was representative of the board's will. Kimberly?
In thinking about taking this bill and being able to go in with a position that would be support, we had two amendments that we wanted to see in the bill. The first was that we put some terminology and some language around the registration of the CARES program to make sure that it is the system that it should be. The second piece was to add the dispensers, and I have some concerns with adding having the dispensers as part of our support if amended. I would like to ask if it be the will of this board that we move the dispenser piece to something we encourage them to do, but not to hold up our support position because they're not under our licensees. As much as we believe that that's a consumer protection issue, I don't know that that should hold up our support position.
After, and also that for some background, that basically amendment was taken in order to get that bill out of committee. So if they take it, it would have to go back to, it would be a
Right.
hard amendment
Right.
to take.
So move.
Okay.
Is that, just,
Dr.
does
Levine.
that mean it's gone forever?
What do you mean?
In other words, you said it would have to go back to committee, so it's not likely to happen. Does that mean when it goes to the other house, or?
No, it just gets pulled back, and if it was a reason why that bill got out of committee, it would be hard to take it back, and I don't know that they would let it out of committee. You know what I mean? It was taken to get that out of committee, and so if they put it back in, it would probably have to go back to committee and be to the first committee. So it would just be another hurdle, basically.
I would move support for the revised position.
Okay, thank you. Second. Is there discussion or questions from the board? Yes.
Yeah, I still have some concerns to remove it, mainly because it's a second level protection. And we are taking away the level 2 protection. Level 1 is the physician to check, make sure that what the database shows, and level 2 is for the pharmacist to check and call the physician's office, which routinely happens. I don't know what the politics behind is, but as a...
Well, the politics are that the pharmacist check is not going to get in the bill, as I understood from our legislative director. So if our support of cures of this bill is conditioned on the inclusion and amendment of the pharmacist check, it would inhibit our advocacy and support of the bill.
I think we could fashion our letter to encourage that we believe this is a good thing, but I think we could still maybe support it as long as they took care of that other issue,
Right.
make our position known, but still be supportive
I
That's,
can live with that.
thank you, Dr. Levine.
Strongest of terms that we really would love.
There you go.
Be very
Thank you.
strong.
Make the case.
No, it's, that second level of protection is absolutely vital, and we would hope it would have been in the bill, but we're dealing with the facts that we have. I'm going to open up, because we've sort of clarified our position, open up comment to the public. See no comment from the public. Is there any comment on the phone?
Not at this time.
Ms. Toof, please call the roll.
Dr. Bolat? Aye. Dr. Bishop?
Aye.
Dr. Gonadev?
Aye.
Dr. Hawkins? Dr. Kraus?
Yes.
Dr. Levine?
Aye.
Dr. Lewis?
Aye.
Dr. Yip?
Aye.
Ms. Pines?
Aye.
Ms. Shipsky?
Aye.
Ms. Wright?
Aye.
Ms. Yaroslavsky?
Aye.
And Mr. Serrano Sewell.
Aye. Dr. Hawkins?
Aye, Dr. Hawkins.
Thank you, and thank you for that clarification. We appreciate it. And thank you to Jennifer. That was an outstanding job. If the board, we can stand in recess for 3 minutes.
Oh.
Three, because I know it's always a little longer. We'll reconvene in 3 minutes. Thank you. The medical board is now back in session. We'll continue with the final item, and item 6B.
6B. Agenda item 6B is the status of regulatory actions. The matrix is in your board packets, tab 6. Do any members have questions on the matrix?
I see no questions, comments. Thank you for your report. We'll now move to item number 7, possible action on 2016 proposed board meeting dates. Ms. Crookmeyer.
Good afternoon. I'd like to draw the board's attention to BRD 7-1 in your packet. And then also there was an amended version that was given to you dated 5/16. So I'm trying to set up board meetings for 2016, and after I had sent out the original one, I received a comment from a board member that could not make it on the first Thursday of every month. So I tried to rearrange it, and then in looking, I had rearranged it actually with the April date being around Passover. So I'm going to go back and use the old form. I'm going to ask that we look at the dates on the old form for the May meeting, the May 5th and 6th in LA, July 28th and 29th in the San Francisco Bay Area, October 27th and 28th in the San Diego area. The only one that I really have an issue with is January and February. January 28th and 29th doesn't work for one member, and February 4th and 5th doesn't work for another member. And if I moved it up one for January, it would fall too far for the May meeting. So we would run, it would be too far in between the two meetings. It would be 15 weeks. So at this point, I'm going to have to ask for the vote of the board, and there may be members that aren't able to attend. So that's, I would actually like to separate the motions and go first for May, that's okay, May 5th and 6th in LA, July 28th and 29th in the San Francisco Bay Area, and October 27th and 28th in the October area. I'd like to entertain a motion for that.
Point of clarification. Okay, point of clarification. In the past, the reason that these areas and regions of the state were chosen was because we had board members in those areas.
They're chosen actually because it's in the law that we have to go around the state.
Right, I understand, but not specifically the city.
Yeah, no, yes.
So I don't know if the January or if any of those meetings, if it makes it for the people that gave you a problem for those dates, maybe if you moved it to a different location.
I'm looking at, no.
No, okay.
Comment. Yes. Traditionally, since I've been on the board, we've done it Thursday, Friday. Is there anything set in stone there's anything set in stone that it could not be a different day of the week because it's Thursday and Friday has just been traditional or easier for us to get out or
Be
just-
Thursday, Friday, and Saturday. It used to be 3-day
Yes.
meetings.
Yeah. So
just asking.
it's gone over yeah, Ms. Yaroslavsky is correct. It's changed from Thursday, Friday, Saturday to just Thursday, Friday, and then sometimes we need to add Wednesday depending on what we have. There is nothing requiring us to stay on Thursday, Friday. At the time, I believe, and I would have to go back and ask someone else probably was in exec longer than I was. I believe it was probably the best dates possibly for physicians was Thursday, Fridays. And that's what I believe it is, but there's nothing to hold us to that date. That would be up to the board to determine that.
Are you asking for 4 separate motions, or can you restate?
No, I'm only asking for 2 separate motions, actually, because I think we're going to have to go by vote on the January, February date.
Okay.
So it would be May 5th and 6th, July 28th and 29th, and October 27th and 28th.
Right, so I moved on that one. I moved a motion on that one.
All right, there's a motion and a second. Are there additional comment from the board members? Dr. Levine, yes.
What is the issue about too much distance between the meetings?
So for the proposed decisions by an administrative law judge, we only have 100 days to act upon those. And spacing it out from that January one would give us 105 days. We could do it, but you might have to have an interim meeting. So that would be the option. We could go to January 21st and 22nd, and then just know that between January and May, there may be a need for an interim meeting. So that's the.
Can we vote on that as a third option?
Yeah, you could, we haven't voted on the January
Oh.
one, so we'll put that out. We can have a motion. I'll let somebody motion for that, and then we can.
Pardon me. So we're on May and July and October 27th and
Yes.
28th. Yes, sure, okay.
The motion would be to approve May 5th to 6th, July 28th and 29th, and October and 27th with the areas addressed in 7-1 for the 2016 board meeting dates.
Okay. Motion and a second. Yes, Dr. Kraus.
Oh,
There's
you
been a
can vote on
motion
that.
and a second. Do you have a comment?
No, that's fine.
Okay, thank you. Do I have to take public comment? Is there any public comment? Any comment on the phone?
Not at this time.
Thank you. All those in favor of the, Ms. Toof, please call the roll. Thank you.
Aye. Dr. Bishop? Aye. Dr. Gonadev?
Aye.
Dr. Hawkins?
Aye.
Dr. Kraus?
Aye.
Dr. Levine?
Aye.
Dr. Lewis?
Aye.
Dr. Yip?
Aye.
Ms. Pines? Ms. Shipsky? Ms. Shipsky? Ms. Wright?
Aye.
Ms. Yaroslavsky?
Aye.
Mr. Serrano Sewell?
Aye.
Thank you.
Then for a second motion, I would like to ask for a member to make a motion as to the date, either January 21st, 22nd, January 28th, 29th, or February 4th and 5th, and see if we can get an approval.
So moved.
I would,
It has to be one of those dates.
I would like to move for January 21st, 22nd, and state the reason, and if I can have your indulgence. I'm not embarrassed to say that I'm the one with the first Thursday problem, because the first Thursday of each month I volunteer for a once-a-month neuro-ophthalmology clinic at the West Los Angeles VA hospital. And that's something I feel strongly about remaining committed to. So if we could have the January 21st, 22nd meeting instead of February 4th, 5th, that would allow me to maintain both commitments.
Well, we'll try to accommodate. Thank you for sharing that.
Thank you.
So your motion is for the 21st and 22nd?
Yeah.
Yeah.
Okay. Is there a second to the motion? Second. Thank you. Any discussion?
The problem is there's a long span between that date and May 5th to 6th, so there may be an interim meeting for the panels. That would be the only thing.
And you can't do that by phone.
We can, if it's not an oral argument, absolutely.
Oh, so we could do a telephonic meeting.
Yes, you can
I
if
see.
it's not,
All
yes.
right, thank you.
Okay.
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 There's a member that can't make the 28th and 29th on their calendar.
Tell them that. No, we're doing, you guys, the choice is the 21st and 22nd, and everybody's fine, and if there's an interim meeting, there's an interim meeting.
Okay,
This way
thank you.
everyone can participate, so let's,
All right, no, thank you. We try to be accommodating, and we are. So is there any comment from the public? Any on the phone?
Not at this time. Thank
Please call the roll.
Dr. Bolat? Aye. Dr. Bishop? Aye. Dr. Gonadev?
Aye.
Dr. Hawkins?
Aye.
Dr. Kraus?
Aye.
Dr. Levine?
Aye.
Dr. Lewis?
Aye.
Dr. Yip?
Aye.
Ms. Pines? Ms. Shipsky? Ms. Wright? Ms. Yaroslavsky?
Aye.
Mr. Serrano Sewell?
Aye. Thank you. Motion carries. Item 8, executive management reports. Ms. Kirkmeyer.
I would first like to begin by asking for a motion to approve the orders. Have those been handed out, Ms.
No,
Okay,
sorry.
then I'm going to move on and I will come back to that if I can remember that.
Thank you.
Okay. I will not be going over all of the administrative summary, the enforcement program summary, or licensing program summary. However, I do have a few items that I want to point out. As indicated in the enforcement summary, the board staff is diligently working to decrease the amount of time it takes to perform the review of complaints within the central complaint unit. Unfortunately, without having the workload reports needed, we were unable to identify the length of time it takes in our complaint unit. We were able recently to run a few reports that still need further review and verification, but what it indicated is that the time in this unit needs to be a priority. To that end, Ms. Romero has been working with the managers in that unit to perform case reviews. In addition, we have authorized overtime in this unit in order to review and take action on these cases. Lastly, we are also meeting with a Breeze expert from DCA on Monday to determine if there are any business process changes that could be made to make the processing more efficient, or if there are any system shortcuts that could assist in the time frame to process the cases in the database. Prior to going to Breeze, our case review was the lowest it had been in 5 years, and we are working to determine the reason behind this increase. We do recognize that we have vacancies, but not significantly different than we have in the past. I will continue to work with Ms. Romero and the managers in the Central Complaint Unit to identify efficiencies and improve the length of time for case processing in the Central Complaint Unit. We also have this individual from DCA reviewing our application process and licensure process to determine if there are any changes that we can be made in our processing in this unit as well. Moving on, I also wanted to let the members know, as stated in the enforcement program summary, that the memorandum of understanding with the California Research Bureau is in the final stages to get approved. We have worked with the legal counsel, and now we're going to be finalizing that and then sending that to the California Research Bureau. Again, because the California Research Bureau has to maintain the confidentiality of those records that we have, including the patient's names and the physician names, we had to make sure that our legal counsel reviewed this and wrote an appropriate memorandum of understanding. Therefore, we will be submitting that hopefully by the end of next week to the California Research Bureau for their review and action on this as well. I also wanted to provide a CARES update since the information in the board packet was completed prior to my most recent meeting on the Breeze project. I wanted to let you know that the new system is scheduled to be released July 1st, 2015. However, the streamlined registration process will be available in August 2015. More testing will need to be done in order for us to finalize this. However, even though the streamlined process will not be available, physicians will be able to register online, but will still need to provide their notary and documents. They will just need to be scanned into the system and attached to the online application. There will no longer be a mail-in application. Some of the improvements, the feature, and the changes that will be available to individuals who are in the system on July 1st will be increased speed of the system. Searches should now return within seconds, not hours, and the system should not crash when an individual who has a significant report is queried. In addition, users will be able to save searches. Physicians will receive alerts when certain criteria is met regarding physician prescriptions, and physicians who have a pain management contract with a patient that does not allow for any prescribing by another physician can ask for an alert if the physician were to have another, or if the patient had another physician prescribed to them. All of these are great improvements to the system and have the potential of assisting with consumer protection. We continue to assist in getting individuals registered, and due to some great outreach prior to the meeting, we have had several individuals register today, and hopefully it will be the same tomorrow. On BRD, so that's my CARES update. Are there any questions so far?
When the program was in its initial design phase, there was talk of expedited access through an electronic health record. Is that design feature in?
That is not in the initial release on July 1st.
Is that?
I believe that's in, I'll check with DOJ, but I believe that's in the second reiteration of what they're looking at. I can't remember the term that they're calling that. I'm not sure that it's in scope, but it's something that they're working on.
So there's no commitment to do it?
Not at this time, yeah. Any other questions? Okay. On page BRD 8B-4, there is a short synopsis of the recent Supreme Court decision entitled North Carolina State Board of Dental Examiners versus the Federal Trade Commission. I just wanted to let everyone know that the Department of Consumer Affairs is working with agency and the governor's office on evaluating this decision. No action is needed at this time, and I will provide more information as it is received from the department. Lastly, I wanted to provide an update on the coordination with other state agencies regarding the issue of prescribing psychotropic medications to foster children. We just recently finalized and signed the data use agreement with the Department of Healthcare Services and the Department of Social Services. We should be receiving the data we requested within the next 2 weeks. During the process, we found that we would need to receive de-identified information. Once that information is received, we will work with a medical consultant to identify specific cases, and then we will need to work with the Department of Social Services in order to obtain patient releases so we can obtain medical records and then investigate the case. I also wanted to draw your attention to pages BRD 8E-1 through 8E-19. The Department of Healthcare Services and Department of Social Services has established a quality improvement work group that work together and develop these guidelines for the use of psychotropic medication with children and youth in foster care. Once these guidelines were issued, we put them on our website, sent out an email to all physicians, and also tweeted about the guidelines. The work group wanted to provide tools for physicians that would help them in the future. This concludes my report with the exception of going back to the approvals, and so therefore I'd like to ask for a motion now that they've been handed out to approve the orders following completion of probation and orders of license surrender during probation.
There's a motion and a second. Is there any comment from the members? Any comment from the public? Any comments on the phone?
Any comments on the line?
Not at this time.
Thank you. Please call the roll.
Dr. Bolat?
Aye.
Dr. Bishop?
Aye.
Dr. Gonadev?
Aye.
Dr. Hawkins?
Aye.
Dr. Kraus?
Aye.
Dr. Levine?
Aye.
Dr. Lewis?
Aye.
Dr. Yip?
Aye.
Ms. Pines? Ms. Shipsky? Ms. Wright?
Aye.
Ms. Yaroslavsky?
Aye.
Mr. Serrano Sewell?
Aye. Motion carries. I did have a speaker card from this for this item 8. Did you? Okay, thank you. Moving on.
On to number 9.
Thank you. On to agenda item 9, update on the Federation State Medical, update on the Federation of State Medical Boards.
I'm sorry, I know you mentioned the speaker card, but did you call for public comment on the whole executive report?
I don't know that I think I did, didn't I? Yes, I did. Yes. I did ask the phone, yeah. I think we're okay, so I'm going to move on to agenda item 9. But thank you for bringing that out. I appreciate it. I would like to begin by providing a brief update on the Federation meeting that was held April 23rd through the 25th in Fort Worth. This year's agenda focused on assisting medical boards in achieving their mission of consumer protection and provided several forums where members could learn more about issues concerning medical boards nationwide. The biggest issues of discussion include the latest ruling by the Supreme Court, the Interstate Compact, opioid misuse and abuse, and what state boards have done and are doing to battle this issue, along with continuing medical education. Speakers included a healthcare law expert, the new CEO of ACCME, and the director of the White House Office of National Drug Control Policy, the drug czar. On the last day, there was a presentation by leaders who are focused on physician health. There were also sessions held on working within the team-based care model, accreditation of U.S. and Caribbean medical schools, working with the DEA on opioid misuse and abuse, trends in telemedicine, and communicating with stakeholders. The presentations emphasized how boards can find best practices in order to meet their missions. Would any of the other members who attended like to share their thoughts? No? Oh, yes, Dr. Levine.
Just that we had a great representation from California this year. There were 1, 2, 3, 4, 5 of us.
Yes.
In attendance.
We had Kimberly, myself, Dr. Kraus, Dr. Levine, and Denise Pines. So it was, it's always good. It's a great networking and hearing what other people do, and I found it a very rewarding experience. And Kimberly can, we have some members who are just appointed to committees of the Federation.
I'm very excited to announce that Dr. Lewis was appointed to the Education Committee. Ms. Wright was appointed to the Editorial Committee of the Federation. So congratulations.
Great. Thank you. That was just a report, no action. Moving on to agenda item 9A. Ms. Kirkmeyer, can you discuss the answers that were obtained regarding public concerns on the Interstate Compact?
So as directed by the board at the last meeting, staff went back and summarized the comments and questions from the public regarding the Interstate Compact. In addition, once that summary was put together, we sent them to the attorney and staff at the Federation. We have received the responses, then they have been included in the packet beginning behind tab 9, starting with BRD 9A-1 to 9A-7. Board staff believes the responses have addressed the questions. I'm not going to go over each response that's in the packet, but I would like to update the board on the status of the compact nationwide. 6 states have approved the compact, and it has gone through their legislative process and signed by their governors, so it is now law in those states. Only 1 more state is necessary for the commission to be started. 11 states have legislation introduced, and they're going through the process. At this time, it is too late for the California legislative calendar to put the compact into legislation this year unless there was a gut and amend bill, but we haven't been notified that that's going to be happening. At the last meeting, the board directed staff to work with the legislature to determine if the compact would be interested in this, be of interest in this state. Now that we have received the responses to the comments, we could begin discussions to see if there is any interest in possibly a bill next year if author wants to carry it. Does anyone have any questions?
Do members have any questions? I don't see any. I think I have pardon me, a comment, public comment card from Julie Felmuth on this.
Good afternoon. Is this on? Julie D'Angelo Felmuth from the Center for Public Interest Law. We continue to oppose approval of the Federation's compact for all the reasons that we've stated at 2 of your prior meetings. The fact that it must be approved as is and cannot be changed, even to resolve apparent internal inconsistencies, which I do not believe are resolved by the answers that you've been given by the Federation. The fact that its provisions will, quote, supersede state law in ways that we cannot even anticipate. The fact that it superimposes over all state medical boards a huge interstate commission that has not yet been created, may have no public members, will be able to adopt regulations that supersede California laws and has a giant question mark over it when it comes to cost. And also the fact that you will be required to rely on other states to perform background checks on doctors who want to practice in California. But the biggest reason you should not vote to approve this compact today occurred on February 25, 2015, when the U.S. Supreme Court issued its decision in the North Carolina Dental Board case, as Ms. Kirkmeyer pointed out to you. This U.S. Supreme Court decision is, in our view, a significant game changer when it comes to professional licensing boards like this one, whose composition is required to be dominated by active market participants, that's the term the court used, meaning practicing physicians, who are controlling the regulation of physicians in California. I do not have time today to fully explain the significance of this somewhat complex decision, and I believe that's up to your lawyers more properly. But suffice it to say that if you, as a physician regulatory board dominated by practicing physicians, vote to approve this compact, which delegates a portion of your licensing authority to other state boards that are dominated by physicians, and they all are, even more so than this one is, and another portion to the Interstate Commission, which will, in all likelihood, be controlled by physicians, you will risk running afoul of the federal antitrust laws. And there are significant legal consequences for running afoul of the federal antitrust laws. North Carolina Dental Board is a significant decision which all 50 states must grapple with. No state has done that yet, including California. Frankly, everybody's in denial. Everybody's running around seeking legal opinions to explore the options and figure out how each state wants to implement this decision. Nobody knows how it will be implemented here in California. Nobody knows whether what any state does will be sufficient to satisfy the decision. I would also like you to know, however, that the Federation and the American Medical Association submitted a friend of the court brief to the Supreme Court in the course of its decision, and every argument in that brief was rejected by the majority. The Federation and the AMA were dead wrong. We actually think that you should ask the Federation to go back to the drawing board and re-look at the compact in light of this decision. The bottom line is that there is no need for you to approve this compact today. I would strongly suggest that you not do it. There's no need for you to do it until you receive more information from your staff and your attorneys about the impact of this decision and whether your approval of the compact might expose you to federal antitrust liability. Thank you.
Thank you. It is not the board's intention to take action today. Yes, ma'am. Please come up.
I'll give you this.
Yeah.
My name is Lisa McGifford. I'm with Consumers Union Safe Patient Project, and I won't go over all the things that Ms. Felmuth went over, but we support, we agree with the points that she made and ask you not to move forward on this compact at this time. There are a couple of things that we would like to recommend if you do move forward, and one is that this body recommend that the legislation in California say that your appointee will be a public member to assure that there's a public member on this. We're also concerned about the public access to the work that this compact does and this commission does. It's going to be further removed from consumers, and we would urge you to work with the Federation to make sure that all their meetings are webcast so that the public across the nation can see what they're doing. We're very concerned about removing the regulation further and further from the people who live in this community and other communities. Thank you.
Thank you for your comments. Are there any additional comments from the public on this portion of the director's report? Are there any comments from the phone?
Not at this time.
All right. Thank you for that update. Anything else? That concludes item 9. Now moving on to item 10, update on and implementation of regulations for uniform standards for substance abusing licensees. Ms. Kirkmeyer.
This is my last item. Okay, so please turn your attention to tab 10, BRD 10-1, and I'm happy to report that our regulations for the uniform standards for substance abusing licensees were approved and will become effective July 1st, 2015. As all of you know and have felt the pain, this was a very long process, but we're glad that they were finalized. We have to meet with the Office of Administrative Hearing and the Office of, or the Attorney General's office to go over the standards and explain the need to adhere to them if they choose one of the conditions listed. We will also be putting them on our website, notifying interested parties, and we'll have an article in our July newsletter. So again, you know, the importance of these are that these standards have to be put into the decisions as written when that decision is chosen. And so that's something that as decisions come through, our attorneys will be reviewing, as well as the deputy attorney generals will make sure that those are going into stipulations where there is a substance abusing licensee. So this is going to be a big impact to the board, but obviously the regulations are approved, and so we'll be moving forward in that vein. So are there any questions on it? We'll be putting together a packet that we were able to get out to the OAH, that's the big one, AG's office, and then also to the Defense Bar, so they know that it's going to be coming.
Are there any comments from the members? None? Seeing none, are there any comments from the public? Yes, please.
Very quickly, Julie D'Angelo, Falmouth from the Center for Public Interest Law. I just want to thank the board and the staff, and especially Ms. Webb, for your very, very hard work and conscientious work on these uniform standards. Thank you. You've saved a lot of lives.
Are any additional comments? Any comments from the phone? Oh, I'll get to you.
I'm sorry, this is Lisa McGiffer with Consumers Union. We also want to thank you for finally getting this done. I feel like we've been bringing this to you for a couple of years, and we're very happy to see it done and appreciate the commitment of the staff and the board to move forward, and we think it'll make a big difference in the future and protect consumers. Thanks.
Thank you. Thank you for that comment. Any comments from the phone? No, thank you very much. Seeing no further comment, we'll move on to agenda item 11. Discussion and possible action on Midwifery Advisory Council member appointments. Mr. Warden.
The Midwifery Advisory Council has 2 positions that are coming vacant, or should say expiring on the June 30th of 2015. The board advertised those positions. One was for a licensed midwife position, and one's for a public member position. At the March 26th, 2015 Midwifery Advisory Council meeting, Ms. Lope, our licensing manager, presented to the MAC members 3 applicants for the expiring licensed midwife position and 6 applicants for the expiring public member position. The MAC members voted to recommend to the board to reappoint Carrie Sparavon for the licensed midwife position, and that new appointment would expire on June 30th, 2018. And I would like to request a motion to reappoint Carrie Sparavon to that position.
So moved.
There's been a motion and a second. Is there any discussion? Is there any public comment on the motion? Any comment from the phone?
Not at this time.
Thank you.
Ms. Toof, please call the roll.
Dr. Bolat? Aye. Dr. Bishop?
Aye.
Dr. Gonadev?
Aye.
Dr. Hawkins?
Aye.
Dr. Kraus?
Aye.
Dr. Levine?
Aye.
Dr. Lewis?
Aye.
Dr. Yip?
Aye.
Ms. Pines? Ms. Shipsky? Ms. Wright? Ms. Yaroslavsky? Mr. Serrano Sewell?
Aye. Motion carries. Next item, item 12, update and possible action on, I apologize. Oh, I'm sorry. Forgive me.
The MAC members voted to recommend to the board to reappoint Barbara Yaroslavsky to the public member position, that would expire on June 30th, 2018. I'd like a motion to reappoint Ms. Yaroslavsky.
Seconded.
It's been moved and seconded. Are there comments from the members? Seeing none, are there any comments from the public? Seeing none, any comments from the phone?
Not at this time.
All right. Ms. Toof, please call the roll.
Dr. Bolat?
Aye.
Dr. Bishop?
Aye.
Dr. Gonadev?
Aye.
Dr. Hawkins?
Aye.
Dr. Kraus?
Aye.
Dr. Levine?
Aye.
Dr. Lewis?
Aye.
Dr. Yip?
Aye.
Ms. Pines? Ms. Shipsky? Ms. Wright?
Aye.
Ms. Yaroslavsky? Mr. Serrano Sewell?
Aye. And thank you, Ms. Yaroslavsky and Ms. Sparavon, for your continued service on this important committee. Moving on to item 12, update and possible action on recommendation from the Midwifery Advisory Council meeting. Hello.
Hello, good afternoon. Thank you for the reappointment. I look forward to continuing the work we're doing on the Midwifery Advisory Council. I trust that everybody's read my report that's included in your packet, so I'm not going to belabor most of the points in there. The one thing that I would like to bring to your attention is that The most important item regarding licensed midwives at this time is the creation of regulations as dictated by AB 1308. Most importantly, the creation of a list of conditions for which a licensed midwife must refer a client to a physician for evaluation. This regulation is currently stalled over the issue of whether history of a prior cesarean should be on the list. I would like to publicly ask the interested parties to continue to work on a compromise to this impasse. I'd like to spend my next couple of minutes, which I know is about all I've got, to update you on a national work group related to midwifery that I was pleased to be a part of 2 weeks ago. The United States Midwifery Education, Regulation, and Association Work Group is comprised of 7 U.S. national midwifery organizations. This year was the 3rd year that they have met, and I was privileged to attend for the first time this year. The goal of this work group is to advance the vision of expanding access to high-quality midwifery care and physiologic birth for all women in all birth settings in the United States. The work group has previously endorsed the International Confederation of Midwives Standards for Education, Regulation, and Association. The American Congress of Obstetricians and Gynecologists has also endorsed these same standards earlier this year. ACOG has reported that the U.S. will experience an 8,000 obstetrician shortage by the year 2020. And I've noticed as I've sat here listening today that this seems to be a theme. We're short of physicians, and we need other providers to step up and help fill that void where it's appropriate. ACOG's president, John Jennings, recognized, along with this shortfall, the lack of an integrated maternity care system such as Europe and Canada have, which obstructs the path for making out-of-hospital birth as safe as possible. The medical board is charged primarily with protecting consumer safety. I want to plant a seed today for what could be a safer future for California mothers and babies. The United States currently ranks 60th worldwide in maternal mortality, behind even low-resource nations like Cuba. And the rate is going up, it's not going down. We know through mountains of evidence here in the United States and worldwide that midwives improve outcomes for low-risk women. I would like the board to direct the Midwifery Advisory Council to create a task force which could look at ways to improve and increase midwifery training in opportunities in California and make recommendations to improve both consultation with and transfer to physicians from midwives when that becomes necessary. I'd like to involve all stakeholders in the conversation so that every innovative idea can be given consideration. And I would view this as not a single year project, but something that maybe we could take on for a longer term. I think that one of the things we could look at is bringing midwifery education to the community college system in California. So, that being said, if anybody has any questions about that little piece that wasn't in your packet.
We normally like to have items in our packet that we're going to vote on.
I would have included this, but I hadn't gone to the work group before I sent in my report.
I understand.
So, that being done, I need approval for the following agenda items. So the task force update on the licensed midwife annual report data collection tool. We have continued work to do there. Update on continuing regulatory efforts required by AB 1308. An update on midwife assistant language for Ms. Simoes. An update and approval of changes to the licensed midwife annual report. Update on the challenge mechanism. And a presentation by Diane Holzer on the Home Birth Summit recommendation regarding best practices for home-to-hospital transfer for midwives, and your consideration of a task force, perhaps maybe not at this meeting, but maybe your July meeting.
Sure,
planted the seeds.
Why don't we take up the agenda items, the approval of the agenda items, Is there a motion?
Yes. So
It's been moved by Ms. Yaroslawski, seconded by Dr. Levine. Is there any discussion from the board members? Excuse me. Any comments from the public? We have one comment. Jennifer Camel. Hello. Hi.
Hi, I'm Jennifer Camel, a consumer advocate focusing on post-cesarean birth options and founder of VBAC Facts, an educational resource for consumers and professionals. I appreciate the opportunity to speak to you today on behalf of consumers regarding AB 1308 and the importance of access to vaginal birth after cesarean. I'll be focusing on the impact of requiring women seeking out-of-hospital VBAC to obtain physician approval. This proves problematic because very few physicians, if any, would be willing to sign off on a home VBAC due to liability concerns. This would effectively cut off the option of vaginal birth after cesarean to many women throughout the state. Some people may think reducing access to out-of-hospital VBAC is not a big deal, but 44% of California hospitals ban VBAC and mandate repeat cesareans, despite ACOG's and the NIH's assertion that VBAC is a safe, reasonable, and appropriate option for most women. Yet consumers report that many facilities provide incomplete or misleading informed consent and maintain a strict VBAC ban. These facilities lead women to believe that a repeat cesarean is their only option. But ACOG's latest VBAC guidelines are clear that, quote, even if a center does not offer trial of labor after cesarean, such a policy cannot be used to force women to have a cesarean delivery or to deny care to women in labor who decline to have a repeat cesarean delivery, end quote. But this recommendation is simply ignored by many facilities. As Dr. Elliot Main, medical director of the California Maternal Quality Care Collaborative, has stressed, quote, in California, we're seeing a lot of hysterectomies, accretas, and significant blood loss due to multiple prior cesareans. Probably the biggest risk to the first cesarean is the repeat cesarean, end quote. Nevertheless, VBAC is simply not an option, and it's not occurring in many communities throughout the state of California, resulting in a 9% VBAC rate statewide. That means that 91% of women with a prior cesarean have a repeat cesarean. According to a 2013 study on hospital VBAC bans in California, quote, among the 56% of hospitals that offer trial of labor after cesarean, the median VBAC rate was 10.8%, end quote. So even in a facility that offers VBAC, attaining a VBAC and avoiding surgery can be elusive. It is within this climate that women choose out-of-hospital VBAC. In many communities, VBAC is simply not an option at their local facility. Barger 2013 found that, quote, the mean distance from a non-TOLAC to a TOLAC hospital was 37 miles as the crow flies, with 25% of non-TOLAC hospitals more than 51 miles from the closest TOLAC facility. In 2012, 139 hospitals offered TOLAC, which was 16.6% fewer than in 2007, end quote. So the trend is for fewer hospitals to be offering TOLAC, resulting in more women having repeat cesareans. If a hospital VBAC is not a possibility and the choice of out-of-hospital birth is removed, that essentially forces women into either unwanted and unneeded repeat cesarean surgery and the increasing risks that come with multiple prior cesareans, or into unassisted home births where they deliver without a midwife or a doctor.
Please conclude your comments.
I was at the last sentence.
Okay.
Perfect timing. In light of the recommendations made by ACOG and the NIH and the realities of increasing morbidity rates in the state of California due to multiple repeat cesarean sections, the objective should be making VBAC more accessible, not less. Thank you for your time.
Thank you for your comments. Ms. Baravan, if it's okay, I'm going to recommend that you consult with our executive director on the task force and prepare a report
Perfect.
for the July, if that's okay. Well, thank you for
That'd
your
be
time.
great. Did we
Oh, we have to vote.
You
I'm
have to-
sorry.
I need
All right,
agenda
wake up.
items for.
Yes,
our
yes,
next
we will
meeting.
vote on that. No comment from the board. Got any comment from the phone?
Comments on the line?
All right.
Hi, this is Shannon. Hi, this is Shannon Smith Cali representing the OBGYN. And I agree with Ms. Baravan on all of the agenda items. It's really tough on getting to this last issue on the regulations, and we may have to come back and do some legislation. I just want for the record to say there were some things that we very carefully crafted the legislation with the California Association of Midwives to allow for the home VBAC option, which is not something that ACOG approves of at all. But we want to make sure that people have choices. And we completely prohibited kinds of deliveries that we agreed were too risky, including multiple births and breaches. And we actually might have liked to have completely prohibited VBACs, but we recognized we didn't want women to go unattended. So the way that we crafted it was the midwife needs to send the woman to a physician. The physician does a consultation with the woman and doesn't approve of a home VBAC, but just says whether or not the physician thinks it's likely that the woman will be able to have a successful trial of labor and have a successful vaginal delivery. So all we're asking for in the legislation and the regulations is a physician consultation on all prior cesareans, and along with a whole other laundry list of conditions that nobody else is objecting to those other conditions. So this one issue that's holding up the regulations. So we'll continue to discuss, but I'm not optimistic that short of legislation we'll be able to get this fixed.
Thank you. Now, we've heard the public comment. We're going to make a motion. We're going to vote on the motion now. Please call the roll, Ms. Doof.
Aye.
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 All right, Dr. Yip? Ms. Pines? Ms. Shipsky? Ms. Wright? Ms. Yaroslavsky? Mr. Serrano-Sewell?
Aye, the motion carries. Thank you very much. We're going to take a couple things out of order, as I stated earlier, and we'll go to item 17, update from the Department of Consumer Affairs. Ms. Christine Lally. Good afternoon.
Whoops. Yep, it's on. Good afternoon, President and members. I'm Christine Lally, Deputy Director of Board and Bureau Relations for the Department of Consumer Affairs, and it's always a pleasure to be with you. And I thank you for the opportunity to update the board since the January meeting. I first would like to start with a sincere congratulations to our two newest members, Dr. Hawkins and Dr. Bolat. Pleasure to be here with you today. I know you were both appointed by the governor in March, and we're very excited to have you on board and even more excited to work with you. So congratulations on your first meeting and welcome to the board. I also have an update from our executive office. I'm very excited. Oh, sorry. A little hungry. I'm like, what's that? Sorry. Sorry. Distracted. Squirrel. Okay, I'm back. I have an update from our executive office I'm excited to share with you today. Just yesterday, by a vote of 4-0, the department director, Awit Kadani, was confirmed by the Senate Rules Committee. The committee's action advances Director Kadani's confirmation to the Senate floor for final approval. Like most of you serving on this board, directors appointed by the governor must be approved by a majority vote of the Senate within 1 year of assuming office. We are very proud of our director and anxiously await the final Senate floor vote. Yesterday was a really good day.
Yay.
Another item I just wanted to touch on, since we're almost halfway through this year, I just wanted to take the opportunity to remind the board members of required trainings. The Form 700 annual statements, as you know, were due in April, and I thank the board for your commitment to that and getting them in timely. For our newest board members, just wanted to remind you that we have board member orientation training coming up in June 18th in Van Nuys, and we also have another training September 23rd in Sacramento, if that works for your schedules. And also remind board members reappointed to the board, you're also required to take training within 1 year of your reappointment to the board. Also of note on trainings, 2015 is a mandatory sexual harassment prevention training year. So that means that all DCA employees as well as board members, even if you took the training last year, need to take it again this year. So we thank you for your attention to those important trainings. And if you ever have any questions, please feel free to give me a call. Next, I wanted to take a moment to update the board on the Breeze project. I know that your executive director had a brief overview in the administrative update, but I just wanted to take a moment to touch on a few items. In March, the Joint Legislative Budget Committee approved the department's Section 11 request for contract amendments to the Breeze project. With this approval, the Breeze project will conclude after the launch of Release 2. The department will address the needs of the remaining 19 boards and bureaus not on the Breeze system once Release 2 is launched, which we anticipate will be early next year. After the launch of Release 2, the department will conduct a cost-benefit analysis to ensure that the Breeze system is the most cost-effective solution for the remaining boards and bureaus. The department remains focused on ensuring that the needs of Release 1 boards, such as the medical board, are being met and that the launch of Release 2 is very successful. An example of our commitment to Release 1 boards and Release 2 are the Breeze enforcement reports. The department, in collaboration with staff from the boards, have been developing 4 new enforcement reports. The first of these reports will be for the performance measures and available at the end of this month. The remaining 3 reports will be ready at the end of June. One of the department's primary concerns has been to make sure that these enforcement reports are complete and accurate. After the time and efforts invested by the department and board staff, we are confident we have achieved this. The department is also working to assist the boards with tracking licensing workloads. While the department began providing boards with specific license data to help meet this need in April, there are still some issues that we anticipate will be resolved in the coming weeks. We appreciate the constant feedback from the executive officers and board staff, and I want to assure you that the department is working diligently to ensure that the boards have the reports they need to carry out their duties, as well as, most importantly, the data to provide to you as board members. From the feedback we've received, we have learned additional training is needed in terms of utilizing the reports. We are exploring ways to assist staff, especially executive officers, with understanding, accessing, and using the reports available on the Breeze system. We are also asking the board submit tickets, if you will, to the department's IT service desk if they have any questions or problems with any of the reports, to request specific creation of detailed designed reports, or to request a specific data extract that the DCA Breeze team can assist with. So I know obviously reports have been a very important item for your executive director as well as the board, so we're definitely committed to that. Finally, I wanted to just briefly update on or touch on a subject that just came up recently, and that's regarding the Supreme Court's recent decision and the implication it has to the department's boards. In late February, the Supreme Court of the United States issued its 6-3 decision in the case of North Carolina State Board of Dental Examiners versus the Federal Trade Commission. The case involves whether or not North Carolina's dental board was immune from federal antitrust laws. The court concluded that the North Carolina State Board of Dental Examiners, consisting of a majority of dentists, cannot be allowed to regulate their own markets free from antitrust accountability. I want to assure the board that DCA's legal office is proactively discussing the decision, the impact and consequences of the application of the decision with respect to the current composition of DCA boards, and is carefully deliberating on the direction we will take, with special help from counsel at agency as well as the governor's office and the attorney general's office. When discussions conclude with these entities, the department's legal office will provide specific direction to the boards. We ask that you please keep your assigned counsel apprised of any questions you have or receive regarding this decision. And with that, I know it's been a long day and you're looking to wrap up. I conclude my update and offer it up if you have any questions or if there's any issues I can assist with.
Thank you for the report. Are there any questions or comments from the members? Dr. Levine.
Christine, thanks for coming, and that's really...
Of course.
Your report is
I
always...
sincerely appreciate and I enjoy being with this board very much.
You said when Breeze, the second release is done, that the project is over?
Correct. So the recent amendments, so the Section 11, and Ms. Kirkmeyer can always jump in anytime because she's a Breeze expert, probably much more than I am. But yes, the recent contract amendments, it ends the current contract as we know it, Breeze, and the remaining boards, which we were calling Release 3, we're looking at how that can happen.
Is there a plan at some point for, or will the system accommodate, for example, medical board staff extracting their own reports from the system?
And that's partly those are the discussions that we're having, because we do have the ability at this point, these data extracts that we can pull out. That's the direction that we're heading in. But our first priority is the enforcement reports as well as the licensing workload reports. And Kim, if you want to.
So the reports that the department is focusing on right now are the performance measurements, which we don't really use them for the board, but they use them because they go in the governor's budget. So they're very important reports that need to be done. We have our own reports that we've built over time. We've been struggling to build them, even working with DCA, that just because of the system that they have. But I have talked to Mr. Piccioni, and I can't think of what position he is. I think he's like the assistant CIO, for lack of a better accurate phrase. But he is working on a database ability that will be able to get us our reports very timely and be able to get what we're looking for. To the extent of the reports that we thought when we first went into the system that we'd be able to get, breakdowns by case type and knowing all of those specifics, I don't think that we're ever going to be able to get to that level, but we will be able to get the reports that we need in order to do workload management and all of the stuff that we need to report to the board, and also to be able to manage the staff.
So, and the reason I ask the question is that contained within the data is a lot of potential learning about predictors of problems. What percentage of physicians who come before the board in a disciplinary proceeding come back a second or third time? And are there things that we can learn from what's in that system that would enable us to do preventive maintenance, if you will? Questions that have come up from board members over the years. And so I just wondered whether...
Those actually, Mr. Piccioni, his answer to this, what he's proposing to kind of overlay on the Breeze system, that will be able to be obtained.
Okay.
Yep.
Great.
So I want to thank you for your report, Ms. Lawley, and I appreciate your presence here as well. And since you've attended all of our meetings, you know of our frustration with the system called Breeze. And I understand it's trying to be fixed, and I understand everyone's working on it, and hopefully it's going to work. But given that the barriers, the restrictions that how it's going to be able to function, is there any possibility that we could go back to the old-fashioned way of paper documentation or something? No. So is there something... My concern is that all this money, all this time, and all this energy has gone into this program that's not in the end going to help fashion where we're going. And my concern is that we don't need to know all about it, but as long as I'm convinced that there's a good working relationship between our executive director and the other executive directors that are in place currently with your office as well as your IT people, and that there will be some wiggle room as to changes or options that will make it more effective, and so that she doesn't have to listen to our complaints. Well, why don't we have this information? So I'm just hoping that it's not, we're fixing the problem that's never going to get fixed anyway mentality. So I'm just hoping that that's not where we're going.
I wouldn't describe that as the department
mentality
at all.
Well, it was not the department, but the system. It's not you, it's the system that's been invented.
Ms. Yaroslawski, members, if I could try to just make a statement, and that is, the state, through its Department of Consumer Affairs, is committed to Breeze. It has learned its lesson, and it will implement it. during this implementation phase, there will be issues, and they'll be dealt with. They will be dealt with by Director Kadani, his staff, and our executive director. So we sort of have to all hold hands and make this work.
I'm fine with that, as long as that's what I want, that's what I was looking to hear.
Most
That-
definitely. And
I was hearing two parallels, and I just want to make sure that
That's where
at
we're
some
at.
point you
And
guys
I
are.
would just add that the executive team, and we have bi-weekly meetings with Kim, and Kim is very forthright on positive and negative issues she's having with Breeze. And what has come out of the recent bi-weekly meeting we had about 2 weeks ago or so is our Jason Paccioni is going over to the board, and Kim's actually walking through the different issues and seeing, is it a server issue? Is it something else that we can tweak? So Kim's requests definitely do not fall on deaf ears.
And as I stated last time, I think it was the how do I say it? The change in the way they're looking at these reports based on people coming back to them at the executive level of DCA is great for us. They have been willing to look at all the problems that we've brought forward. They have a really good work group that meets, and our staff, when they have problems with the reports, they report them back to their staff, and they're working those out before the reports are released. And that's really helpful for us, because we don't want our reports, we don't want to be like, well, we don't like that report. They're working with the staff and with everybody's concerns that are brought forward and making sure the reports are measuring the right thing. And that's been very, very helpful.
Thank you.
Truly been the spirit, is to make
Yeah.
sure that we're all on the same page. Everybody has the same buy-in, because if it's not functioning or not helpful for you, why even have the report? So.
Thank you. Dr. Ganadev?
Thank you, Christine. We truly appreciate you coming here. I think DCA took kind of abuse on the Breeze. My question is that, do you have enough budget resources to really for this to work? I wasn't sure by listening through all the what was going on in the assembly and one of the committees there, that are we committed enough resources that this thing really works the way it's supposed to work? That's what I was very concerned about when Mr. Kadani was being abused there. So that's what I felt. So I just want to know that you have resources.
I think resources is a topic of a lot of discussion at the board level as well as the department. And in fact, it came up yesterday in the director's confirmation, and it actually turned into a very, frank and honest discussion about, we need to know honestly as the legislature what you need to make this successful. So I thought yesterday was actually a good step towards having a frank resources discussion. So I'm hopeful.
Thank you. Thank you for that report.
Thank
and
you.
for being with us. Is there any public comment on Ms. Lawley's presentation and report? Seeing none, are there any comments from the phone?
None at this time.
Thank you. We'll take members with your pleasure, and we'll take one more item, then we'll stand in recess until tomorrow at 9. But I'd like Dr. Bishop to give his report on the Physician's Assistants Board, item 14.
Because of the way things were scheduled, there were actually 2 physician assistant board meetings since the last time I reported. In February, President Bob Sachs of the Physician Assistant Training, or Physician Assistant Board, was pleased to say that there were 2 new California Physician Assistant Education programs, one at Marshall B. Ketchum University in Fullerton, and one at California Baptist University in Riverside. With respect to Title 16, California Code of Regulations, citations for unlicensed practice, the board's legal counsel stated that currently this regulation restricts the board's executive officer to issue citations and orders of abatement and levy fines only in the case of physician assistant who has practiced without a delinquent license. As currently drafted, the executive officer is preventing from issuing citations and fines to those who have never been licensed and holding themselves out as physician assistants. Although the citation and fine is a type of civil action, the issuance of a fine would not preclude the board from pursuing criminal charges for the unlicensed practice of medicine. Based on legal counsel's recommendation, the board voted to initiate the formal rulemaking process to amend Title 16 to allow the board's executive officer to issue citation and fines to unlicensed individuals holding themselves out as physician's assistants. With respect to proposed language for guidelines for imposing discipline uniform standards regarding substance abusing healing arts licensees, a regulatory hearing was held on February 9th, 2015. Let's see. This is complex. This is a long time ago. Okay, discussion possible action to amend or adopt changes to Title 16 California Code of Regulations, disciplinary guidelines. Legal counsel presented to the board a summary of additional amendments to the Manual of Disciplinary Guidelines and Model Disciplinary Orders that she believes will further enhance the document. The board voted to approve the additional amendments and directed staff to take all steps necessary to complete the rulemaking process, including preparing modified text and an addendum to the initial statement of reasons for an additional 15-day comment period. The public comment period began on April 27th and will end May 13th, 2015. The Physician's Assistant Board reviewed and adopted the newly revised edition of the board's policy manual. The revised manual includes a newly adopted professional reporting requirements section. Additionally, the manual was updated to include other technical changes. There is a current discussion ongoing about the accreditation process for physician assistant training programs. The board is concerned that the current national accreditation process may not be adequately addressing the need to increase the number of physician assistant training programs that will be needed to meet the healthcare provider shortage. The Accreditation Review Commission on Education for the Physician Assistant, ARCPA, is no longer accrediting associate degree physician assistant training programs, which is a problem because 2 of the programs in California will be shut down, or in the process of being shut down. And the Physician Assistant Board is concerned about this, but has met with pretty much a stone wall from this body, such that their basic statement is they don't respond to state boards. So we're continuing to investigate what's possible, things we can do to look for other accrediting bodies to help prevent a shortage of physician assistants in the state. Let's see. In the May 4th, 2015 meeting, the implementation of Business and Professions Code Section 3518.1 mandated personal data collection from physician assistants. SB 2102, effective January 1, 2015, requires the Physician Assistant Board, the Board of Registered Nursing, Board of Vocational Nursing and Psychiatric Technicians, and respiratory boards to collect data for the Office of Statewide Health Planning and Development. I won't go over what data is required, but the PAB is working with legal counsel, the department, and other boards to implement the provisions of this bill. Senate Bill 337 we discussed today. And a word of thanks on behalf of the Physician Assistant Board and staff. We would all like to thank the Medical Board of California for your continued support, your Executive Director, Kimberly Kirchmeyer, who we all know is #1, and your staff are always available to assist us. Thank you very much. The next Physician Assistant Board meetings are May 4th and August 3rd, 2015. Well, obviously, May 4th has gone by, so August 3rd, 2015. Thank you.
Thank you, Dr. Bishop, for that report. Are there any questions or comments from the members? Seeing none, are there any comments or questions from members of the public on Dr. Bishop's report? Seeing none, any comments from the phone?
Any comments on the line?
I have a question in regards to SB 277, but if you're not ready for that Q&A yet, I'll wait. I just wanted to make sure I get that in before the call ends.
We dealt with that matter already, and we've since moved on. So,
okay, so
I'm going to get you.
Comment on that. That's still an option or no?
No. But however, I will ask that Ms. Jennifer Simoes, our legislative director, get in touch with you and just take your comments and speak to you about the bill. But the board has other business to consider. Thank you. Is there any? Okay. Be sure to get your information somehow. I don't know how to do that, but.
Yeah, please make sure you get my information.
I will.
I definitely have a public concern.
Okay, of course. If there's, we will get to items 13, 15, and 16 first thing tomorrow at 9 a.m. Otherwise, the board stands in recess until tomorrow at 9 a.m. Thank you very much.